Today, we're going to be looking at early intervention. We're going to be looking at healthcare issues as regards to infant, children, and families. And also too, so we're going to be really looking at some reimbursement issues and being able to get services to our children that need those services. Our first person that's up here today, I want to introduce because she has been such an asset to the state of Mississippi for many years on multiple issues. Dr. Susan Buttress is the chair of the Early Intervention Task Force, and this committee actually has been meeting for over 2 years now. I cannot tell you, I counted up, and I think I stopped at around 1,000 hours that members have donated. If the state of Mississippi had to pay their professional fees for all of the hours that they have donated, we would have been in hundreds of thousands of dollars. So I have to thank y'all for your dedication to the state, for all the members of this task force. They worked on it in year one, and they realized that it just was not enough time to complete everything that needed to be done. And so this committee came back and they have worked in subcommittees. They've looked at programs across the country. And I'm going to start out just by saying this too, because we had testimony on this 2 years ago. We know that early intervention services are the largest ROI that you have in any educational program. And so this committee is dedicated to trying to make sure that we treat our children early and that they get the help they need. And there's a lot of dedicated people to doing that. So I also want to thank the health department. Dr. Edney has been a huge proponent and has really made sure that we pulled the program apart. And hopefully we have some recommendations on pulling that program back together and a lot of things that everybody's done. So Susan, with that, will you go ahead and present the task force final findings?
Absolutely. And I want to thank you so much to this work group, this study group for women, children, and families. What a wonderful, important study group to have. So thank you. I want to thank the legislature too for setting up this early intervention task force. It has been an absolute honor and pleasure to serve in an area that is so very, very important to me. But I also want to thank all of our members from the task force, as you mentioned, the fact that they truly were dedicated, hardworking. Both reports, our 2023 and 2024 task force reports, were really contributed to by each and every one of our task force members. And we had some real leaders in our subgroups too. And I just want to thank everybody. I also want to thank the peer group, who is just amazing and has done some wonderful work. Mary Claire, Emily, Ted, we could not have done this work without them. And then all of our advisors to the task force also. Well, with that said, I'll go ahead and move forward, because what I thought I needed to do first is to make sure that everyone understands exactly what Mississippi's early intervention program is, what it's about. So the State Department of Health is the lead agency responsible for Mississippi. We call it First Steps. Every state does not call it that, but it's Mississippi First Steps Early Intervention Program. And the State Interagency Coordinating Council, the SICC, is the advisory council appointed by the governor. This is a federally mandated group that is appointed by the governor to advise and help assist the State Department of Health in implementing the early intervention program. Now, historically, the program has been underfunded. And in fact, it is funded at a lower level now than it was in 2014. So that's a long time ago, with a lot of inflation and other issues that have gone about. But I wanted to make sure that everybody understood that as I talk about some of the issues that need correcting, there is a fairly large reason that, and one is just underfunded. And so therefore, our children have been underserved. So as I mentioned, it is a federal program. It's the Individual for Disabilities Education Act, Part C. Part B is special education services in the public schools. So Part B was established first, then came Part C, and it authorizes each state to implement a statewide, comprehensive, coordinated, and multidisciplinary program, and it's supposed to provide early intervention services to family with infants and toddlers. That's the birth to 3 years with developmental delays and disabilities. And that sounds great, right? The services can be any one of these or all of them. And traditionally in our state, we have not given behavioral services as part. We have not done a deep dive into family training and counseling, but the other, and certainly the mental health services is a piece that has not been there. I believe everyone on the task force believes that behavioral health services, counseling, mental health services are very important, and you cannot extricate from one from the other when you're looking at taking care of young children. So our early intervention program, according to the Center for Mississippi Health Policy, should probably be serving around 13% of children. With our high poverty rate, our high prematurity rate, and other issues, our low education rate, many of our children need services from birth to 3. In 2022, the Mississippi State Department of Health only served 1.61% of the eligible population. That is far below. Now it's come up a little bit, but still we are below the national average. And we propose that at the minimum, the health department should set its standards of providing services at least at the national average. And our committee members basically believe that we should be serving upwards of at least 10%. We would like to serve all 13%. We would like to serve at-risk children, but again, that increases the cost. Now, the importance of frameworks of early intervention has been pointed out by Frameworks, which is an international group that helps us look at different issues in the right way. And basically the way they frame it, without me reading this, I think this is a great statement though. It talks about how when you are basically building a child, it's from the foundation up. And without, if you look at it as an architectural model, you've got to have a strong foundation if you're going to have a strong individual as an adult. And that foundation gets set, even prior to birth, but certainly after birth and in the first 3 years of life. And let me just give you a few quick points that you need to know. From birth to 3, the brain weight, the brain size triples. It's almost the size of an adult by age 5. So there's this rapid growth. The baby's brains are like little sponges. They're rapidly setting down pathways, and over 1 million neural connections are happening a second, not a minute, a second. And so what an incredibly important time that if we don't intervene early, we won't be able to make a difference later on. So it's a valuable investment. Early intervention is so needed. It's needed in every state, but it's certainly needed in our state of Mississippi. It reduces the need for special education. And in fact, if you look at that, 46% of children who receive early intervention did not need special education. Okay, so we're catching it before they enter school. And if you think about a child who has to fail first in school before they receive services, think about the ding that is on their emotional development. It's not good. So if you bolster the child up early, they'll be better off later on. They'll make better progress and they'll love school more. It also enhances the quality of life. It creates that foundation that I was just talking about, and it helps a child learn to enjoy behavior and health. And it also helps the families know how to help the children. It is definitely an excellent return on our investment. If Mississippi just met the national average of children served by the program, the state would save about $3.5 million of special education costs in 1 year. And over 5 years, 17.7, almost 18 million. Now, if you think about if we serve 10% of our children, it would be substantially more. So keep in mind the return on investment and the ability to make changes is much quicker when a child is young than it is when a child is even in the 3rd or the 7th or certainly in high school. This is a graph, and I don't know if you can see it very well, but it's to point out our surrounding states. Alabama contributes 27, almost $28 million to early intervention. Tennessee, 52 million. Louisiana, 23 million. And Mississippi, 11. And if you look at, again, percentage you may not be able to see, but I'll say it for you. With Alabama, we don't have the amount of state dollars versus federal dollars, but the federal dollars, by the way, that comes into our states is by formula. It has to do with population and other. And so it's a set amount that comes into every state. And then to go over and above those services, the state contributes. So state and other funds that come in from Tennessee, 83% of that 52 million comes in from state dollars or other dollars that come in. Louisiana, 68% of their 23 million, but in Mississippi, only 28% goes in. Now, our state has contributed in other areas, other good areas that are needed for families and children. But our proposal is that it needs to be earlier. We need to do a better job of taking care of these kids earlier. And we need to have a lot more in there. So you guys, I'm talking to the choir here. You already know the early intervention task force was created based on recommendations from the study group on women, children, and families. And first passed in 2023 in the regular session. And after our work and our report that I hope many of you have seen, it sits on the Mississippi State Department of Health website. We had a very extensive report in 2023. And one of the recommendations is that we were allowed to continue our work. And thanks to our legislature, they allowed us to continue the work in 2024. And it was created to study IDEA Part C, early intervention, to make recommendations because we knew we knew that we had some pretty significant problems that were going on. And in fact, our health department's early intervention program was at a needs intervention level, as noted by OSEP, the Office of Special Education Programs. So in 2023, our task force recommended that the health department, with the help of the early intervention task force, create a plan to implement a different infrastructure model for delivering early intervention services. And the reason we determined a different structure needed to be set up was because as the years had gone on over the last at least 10 years, early intervention services has become more centralized within the centralization of the health department. And what seemed to be happening is that there wasn't a clear understanding of what was happening in the different areas of the state. Mississippi, as everybody knows, is a fairly large geographic state, and every area of the state is a little bit different. And so it seemed that the very centralized, with most of the administration centrally, was making it very difficult to have a real hand on the pulse of what was going on. We also said that we needed to determine ways to improve billing. Billing, honestly, the early intervention providers, the majority of them were responsible for their own billing. And so many times, due to the fact that a speech pathologist and an occupational therapist is out there trying to do therapy and at the same time bill for services, and the early intervention, the health department was payer of last resort. So they had to bill first insurance if they had private insurance, then Medicaid if they had Medicaid also. And then if that was rejected, then finally they would bill the health department. So what started happening many times is the billing went straight to the health department. So insurance dollars were not collected. And so the burden fell on the few dollars that were going into early intervention services. That's just one example. Happy to answer some questions on that if we need. The other thing we asked is that the health department, again, with the help that we had and from peer, the research, to provide a financial plan to the legislature with cost projections. And I know the health department is working on that as we speak. We also determined that there needed to be some improvement in policies, procedures, and processes. The referrals, the recruitment for individuals, making sure that services were in the natural environment. So let me tell you, the natural environment, as you know, it could be home, school, church, childcare, anywhere. Most of our children from birth to 3 are not in school. And so the services would be provided either at home or at childcare. Those would be the primary areas, but they could also be services in libraries. It could be services in museums. It could be services everywhere, as long as it was naturally where the child would be. So in 2024, in collaboration with the state health department and other intervention experts, we decided this time we were going to divide into work groups to really very specifically look at those different areas that we were talking about in 2023. To help improve the operation and management of First Steps, and wanted to really look at training and quality control. We also wanted to take a deep dive into a hybrid implementation model where, like I said, the intervention services were more regional, so that there would be offices, and we came upon the name collective. So early intervention collectives, sort of riding alongside the pre-K collaboratives, but not using the same words. So our early intervention collectives could be university-based, they could be nonprofits, they could be private provider clinics, as long as they could qualify to serve children in the way that they are supposed to serve them in the early intervention program. And then we also looked in depth at improved billing and reimbursements, looking at standardizing billing codes, revising prior authorizations, which were sometimes cumbersome, and then offering a centralized billing system through the health department that would then help to take some of the burden off the providers who were trying to give the services. So to help ensure that improvements did happen, we are asking that the legislature increase appropriations to First Steps to invest in Mississippi's future, one of the very best investments there is, to amend the Medicaid technical bill to allow for universal contracting for early intervention employees who are credentialed by Medicaid. That's not happening now. Many times they have to go through all the different MCOs for credentialing. Takes a long time to get through that. Again, very discouraging for people who want to give early intervention services. And then our other recommendation is to create a subcommittee with the state interagency coordinating council to serve as an advisory board to ensure that the Department of Health implements recommendations that we have made as we're going through things. So the health department has already worked collaboratively with the early intervention task force. They've already begun to expand their workforce. They're hiring new staff. They've really looked at what's been going on to make sure they've implemented an early intervention credentialing training to help enhance skills. They've looked at technical assistance. They've collaborated with the Division of Medicaid and continue to collaborate with them. And they've also, we're very excited about this, developed an online referral process to help speed referrals. All of that is great, but the job is not yet done. So early intervention, we're happy that internal changes have already been made. There's more work, like I said. We've got to be more efficient, more effective. We've got to serve more children earlier. Mississippi State Department of Health is the one who's going to have to develop a financial plan for the system reform. There's a lot of information there. I know they're working on it. And the plan is that they would have it so that by the time the 2025 legislature is really working, that they can ensure them that they have a hard handle on the dollars it will take to do the needed changes that need to happen. This is James Heckman. Probably seen it. Every time I speak, I talk about this. The return on investment is huge if you invest in prenatal and early childhood. Preschool, the investment is still good, but look at how it drops once you get into school-age kids. The time, not to say we don't need big investment then, we do. But if we would invest earlier in our very young children, we could make a bigger difference more quickly, and that would be more long-lasting. So the legislature, I have to point out, has made some progress. We got insurance coverage for ABA therapy, applied behavior analysis therapy for children with autism. And you'll hear more about that because we do need increased payment in that. But in children with early intervention who have, for example, not autism, but speech language delays, a fairly easily remediable delay, children cannot get coverage from private insurance. The majority of private insurance does not. There are many plans that do not cover speech therapy. And so many times those children have untreated speech delays until they enter kindergarten. Patterns have already been set. So would like to look at that. Obviously, I don't need to speak to the success of the pre-K collaboratives. They have been very successful. We know that. Our point is that we need to start earlier. The TK Martin pilot project, which is an early intervention regional model, a collective, so to speak, is one that you'll hear about lastly today. Dr. Stratton Gadke will be talking about that, and it's been very successful. So I'm excited about you hearing about that. Later on this afternoon. We've shown that it can be done. So with that, I want to thank this study group. I want to thank the legislature for everything they've done. I want to thank the peer group again, Mary Claire, and I want to thank the health department and all of our task force for everything. And I'm happy to take any questions if we have time.
Senator Wiggins, you've got some questions?
Thank you, Dr. Buttress. Couple questions, and I'll get to the point. On the slide that you mentioned, we're only at the 1.6% and should be at 4%. I'm looking at that, and the question I have is, when you're on these recommendations, who's the gatekeeper of these services? And if a child is born in Biloxi versus a child that's born in, let's say, Sharkey County, how are those parents or those children getting these recommended intervention services? Is it the Department of Health? Is it the private pediatrician? So that's my question first.
Yeah. So with early intervention, a parent can even call and ask for an evaluation. So there is not a hard gatekeeper. The issue is getting, parents knowing about the services. So part of the job of our early intervention services is to get the word out, to make sure that providers, that parents, that anyone who cares about children has a clear understanding. The other issue is that many of our primary care providers, family practitioners, nurse pracs, physicians, lost faith in the early intervention services because they would call, a child would have delayed evaluation, they'd be evaluated, and they'd say, oh, never mind, you don't qualify. And the child would be right on the cusp of being qualified for services. And then all they needed to be was like 6 months older and they would have qualified, but nobody comes back to take a look again. So it's a cadre of issues that have sort of kept that number low. Some of it is funding. Some areas of the state have not had adequate providers out there, and that's why we wanted this collective regional system so that we could grow our own providers in there. There would be jobs for individuals there in whether it were Biloxi or Sharkey County or Claiborne County or wherever we are. So The other thing, every early intervention program has, the state can determine how big the delay has to be before you can receive services. In Mississippi, it has to be a 33% delay to qualify for a single area, or a 25% delay in 2 areas to qualify for services.
Okay, thank you. And then my other question is related to the collaboratives, which I appreciate you mentioning that. One thing or a thing about that that gets, I think, overlooked and hasn't been talked about, that as a requirement of the collaboratives is a health component. And I don't really hear anybody talk about that. And so then you mentioned the collective. It would seem to me the collective can be part of the collaboratives, thus meeting the requirements for the collaborative. And do you have any comments on that?
Well, I will just say one thing that I've said over and over again is health and education, brain growth, and that birth to 3 area are so entwined, you cannot separate them out. It is all one. So you've got to have adequate health, hearing, vision, nutrition, all of that must be a part. I'll say the reason, one of the many reasons, are wonderful people running the pre-K collaboratives, but the standards that are set are very high. The funding is very excellent too. And so the standards are very high, and it's clear it makes a difference when you set high standards. And coming as a physician, talking about early child education, health is so very important. It has to be a component.
Just to comment on that, that's why that law, what you described, the cross-section of education, health, and all the others, that's why that has that in there. And it's been said and it's known that the benchmarks were from the early near, and that was one of them, the health, because it's all together. And so getting folks, not just about the education, but the health, it seems like this is a vehicle that we could use to address the health too. So thank you.
You're absolutely right.
Chairman Blackwell is listening by Zoom today. And so one of the things that he has asked is if you could help us, and we can get people of the committee to help us. You referred to the rates that we need for early intervention services to put in the Medicaid tech bill. And we need to get exactly what those rates need to be to look at it for the tech bill. So we'll work with you on getting those rates and work with the committee and UMMC that can help us pull those rates together. So anyway, thank you so much. All right, our next speaker that we have here today, and Pierre, before I start them, thank y'all so much. Y'all have done an amazing job on this committee, and we thank you. We're going to have Dr. Barbara Saunders go ahead and come up, and members of the Autism Task Force and their family members, we all come up to the table and sit with them today too. Members of this task force, which I used to be on the committee 100 years ago, y'all go ahead and come up to the table and sit. They are here today because of an issue that we're having across the state. We've had 2 of our larger service clinics closed that provided ABA services because of reimbursement issues. And so this is also something too that I'm going to go ahead and say, kind of preempt you just a little bit, is we are training a lot of students across the state, but they are leaving to go elsewhere. We're really educating them for our neighboring states because of our reimbursement issues not being at the level. Now, this legislature 2 years ago did in our tech bill increase our service rates on this, just to let y'all know. But we are finding out that wasn't enough. So you're going to talk today about reimbursement and what's going on with that. So thank you. And I'm going to be quiet and let you have it. Thank you.
You're welcome. And thank you guys for giving me a few minutes to talk about this. I'm a native Alabamian, but really now consider Mississippi my home. I've been here 11 years. My daughter, who's a senior in high school, doesn't ever want to leave, doesn't ever want to go to Alabama, except for visits, of course. But she's applying to all Mississippi colleges. And so this is really near and dear to me just because of the fact that there are, like you said, providers and other people leaving. But as I'll get to in a little while, those aren't unfortunately the only people who are leaving the state. So just a very quick update on autism prevalence. The newest number is 1 in 36. When I started fellowship about 15 years ago, we were maybe 1 in 150, 1 in 160. And so that number has increased drastically over the years. And of course, that means that the number of children here in the state that need to be served has increased. The most recent estimate is about 13,500 children in Mississippi. That's a little less than 2.5%. Who have autism. And all of those children need to receive autism-related services, but a large number of them do not. So what is ABA? ABA stands for Applied Behavioral Analysis. This is what we consider the gold standard in behavioral therapy for children with autism. It uses specific approaches with learning and behavior modification so that they can enhance the positive skills we're trying to achieve, but also so that we can hopefully decrease problematic behaviors and other things that might actually interfere with the child who has autism being able to function as well as they can in their environment. The main things that we use now are positive reinforcement and then structured intervention. ABA is a little controversial in some places because of the way it used to be administered. It was much more of a punitive approach. But over the last several years, they have gone to a more positive model, and that has really helped these children. I have found even changing your command from a negative to a positive with your own child or with a child in the clinic can make a difference. You know, if you say stop hitting, or use gentle hands, you're more likely to get a positive response to the use gentle hands. And so being able to access this type of therapy that really has a lot of evidence base is really, really important. So what is ABA? Again, much more of a positive intervention, positive reinforcement model. It's very intensive. And by intensive, I mean one-on-one with a child and a behavior technician for several hours, several days a week. That's ideal. A lot of the children I see who get ABA might get 1 hour once a week, which is better than nothing, but probably not super helpful. The studies that were used kind of to set this gold standard showed kids getting therapy 4 to 5 days a week, anywhere from 24 to 40 hours total. We don't have the numbers in the state to be able to support that, but, and this is the reason, because it is so intensive. It's flexible. And so like Dr. Buttress mentioned, we might have kids in a clinic room doing therapy. There might be children walking around the clinic doing therapy. They might be down outside doing something with their therapist. With all of the goal is to help the kiddo improve the good things and hopefully see those negative things decrease. But it's hard work. It's hard for the kids. It's also hard for the providers. They are literally on the ground with these children for several hours at a time. So a lot of it looks like play, but it really is so much more. They are tracking data. They are changing what they're doing every few minutes to keep the child engaged. It's hard work for the kid too, but they might have the provider might have to change diapers or, you know, give snacks or get hit or a toy thrown at them. And so it's not all just play and what looks like fun. It is fun, but it's hard work. And so we really feel like we need to make sure that we compensate those providers for the work they're doing, because it's a lot harder than some of the other jobs, just like in our clinic, to be honest. It's a hard job. And the folks we've got right now that are serving the kids we have are fantastic. So this is one of our behavior therapists with one of her clients. And again, I don't know if you guys can see, she's actually holding up a little card. And so she's playing, but then she's asking the child every few seconds what was on the card until the child's just able to say it. That's just one example. That's one of our therapy rooms. We are able to have this because of the very generous donation from a family in the community. Otherwise, we would not be able to serve these kids. It can be as effective as I thought a child had stopped coming. The first week, she cried for 3 hours every day, about 2 doors down from my office. Week and a half later, there's no crying. So I said, did she stop coming? They're like, no. She just finally got into the groove and she's finally starting to make some progress, which a week and a half is quick. But it can, like I said, it can help decrease these behaviors. And that's a lot of what inhibits children from making progress when they have autism, because it's harder work for those who work with them. It's harder for them to really pay attention and engage when they're so frustrated or angry or sad, and they don't have a way to communicate that. So that's why this type of therapy is really, really important. This is the Mississippi Medicaid fee schedule from April of 2023. I know it's really small on the screen, but the main places I'm going to look at are the code for the registered. So these are our rates right now. Just to compare, these are the rates for Alabama and Arkansas Medicaid. So Alabama and Arkansas are paying over $16 an hour. We're paying $12.98. Well, per unit, I should say, not per hour, per unit. And then and that's with the RBT. So 15 minutes equals 1 unit. Most our sessions at our clinic are 3 hours per day. So that's 12 units every day. The 97555 code, that is for the supervision that the psychologist or master's level behavior analyst has to provide to ensure that the therapies are quality, but also to meet the requirements of the licensing board. And then lastly, that is the last code is the code for the parent training that goes into this. We all know that behavior is not going to change, at least as well as it could, unless things are done the same across the board. And so every ABA provider should be providing some family therapy and some family kind of workshops, if you will, to make sure they have the skills to continue the behaviors and the management at home. Louisiana was actually a little higher. That first line is just the New Orleans area. And then the line below it is all the rest of the state. So again, it might only be $2, $3, $4, but when you do 12 units a day, 4 days a week, it really adds up. And along that line, I just wanted to kind of give you guys a billing example. So the RBTs, like I said, 15 minutes is considered 1 unit. In our clinic, the kiddos come for 3 hours a day, so 4 days a week. And then there's also the supervision code and then the family training code. My example does not include that last code though. So looking at our Medicaid, and I compared it to Alabama, if the child is present for the full 3 hours, then we're looking at, after the RBT billing and the supervising psychologist or master's level provider, for 4 days of therapy of $790.48. In Alabama, they are billing for $993.76. And that's 1 child. That's a lot. I mean, that's a big difference. And as you said, when the folks that we're training can't recoup that in their salary, and a lot of them probably have student loans, I would imagine, then it's harder to kind of keep folks here. So why reimbursement matters? One is that the vast majority of the ABA clinics in the state don't accept Medicaid, and it's for this reason. There have been several clinics in the state who did accept Medicaid that either have already closed or may have had to decrease the number of Medicaid clients they could accept. And most of the time, those were the only people in that region that did accept Medicaid. And then the children who have Medicaid, and I said Medicaid only, meaning no private insurance at all, they wait a lot longer to get into therapy because there are a lot fewer places that will accept them. And a lot of them, probably the majority, don't ever get any therapy. We've had families leave the state to get better ABA and other autism-related services for their children. The patients of mine who have left, these are, law-abiding, educated, hardworking families who really just want the best for their child, and unfortunately have had to move out of the state to get that. And then, as Dr. Buttress mentioned, we know that with any kind of intensive early intervention, but especially with ABA, that makes the difference and improves the outcomes. I'll just give one more example and then take questions if we have time, because I know my time is brief. But the first client we enrolled in our ABA program, the first time I saw her with Dr. David Elkin. She was two. She was so hyperactive, we couldn't make any assessments of anything. We couldn't tell if she wasn't making eye contact because she was so hyper. She wasn't engaging because she was so active. So we get her in to some other therapies. We get her in when we start our ABA therapy. And she went from a 2-year-old running around the room, not keeping her clothes on, to regular education at Hartfield in kindergarten, no services. And that's because she was able to get the intensive early ABA intervention that these kids need. Will that be the outcome of every child? Probably not. But if that can be the outcome of any children, that is beneficial not only for that child, but for their parents, for their community, and ultimately for the state. So I just wanted to make sure that, that we don't forget the ABA when we talk about those early intervention services.
So just wanted to get I had a couple of questions about the rate. So ideally, what would our reimbursement rate be for the state of Mississippi? I know we've looked at other states. Of course, every state is different. What would be comparable that you think?
I mean, I think the difference between us and Alabama financially is the Birmingham metro area when you look at the population of the state. And New Orleans is obviously a lot larger too, but I mean, we've got to be paying at least $15 or $16 a unit, or we're not going to get people to stay.
And I think you talked about like how many clinics are taking Medicaid payments or what have you. In Alabama, are they having any of the same issues? Because I've noticed that sometimes in vast areas, we'll talk about getting to a rate of this state and a rate of that state, and that state is still struggling to provide services and things of that nature. Does that seem to be, not an issue in Alabama, or what are we looking at there?
I can't give you numbers, but I can say from my colleagues in the other states that I mentioned, they also have some challenges with Medicaid because of reimbursement there, but it's not as high as it is here. One of my colleagues in Kansas, and she wasn't able to get me information for her state's Medicaid, but she said she knows without a doubt that their most frequent private payer is paying, Medicaid is paying 40% less than what their biggest private payer is. So it's occurring everywhere, but I do think it's worse in states like ours where the reimbursement rates are a lot lower.
And that actually led me to my last question, or a couple of questions. One, what is the average private rate here in the state of Mississippi? And then number two, if we take up our Medicaid rate, does that in any way affect or change what the private rate looks like in the state of Mississippi?
I did my very best to get our private payer rates, but ran into a lot of stumbling blocks. So I was not able to get that data. I don't know that it would necessarily change what they pay, because I don't think we can get to where they are anytime in the near future without having to just take tons of money from something else that also needs funding. So I don't think it would necessarily make the private payers change their rates, at least not initially.
Thank you, and thank you for all the work on this.
Sure.
We have some families here, and I think I appreciate the information. Chairman Blackwell has received the report of the Autism Task Force, and so he has that information in there to look at for our tech bill. But I also want to take the opportunity for y'all to just give a brief moment of the critical, important aspect of ABA therapy. You have had a child, he is older now, and we have shared stories, but the critical difference that you were able to do for your child, can you share just a little bit about that with the committee? Doctor, I'm gonna put you on the spot. Yeah, grab a microphone over there, pull a microphone over, Doc. Punch that green button. I mean, but yeah.
Okay.
Yeah.
Thank you. Our youngest is 12 years old. I'm Vince Herron. I work at UMC. My wife is on the autism, she's one of the vice chairs of the Autism Advisory Group. He got diagnosed at age 2, fortunately, by Dr. Buttress, and he's been plugged in with Dr. Saunders. We've been very fortunate. What ABA's made him able to do is go from, at age 2, staring at the refrigerator to let you know that he wanted something that was inside it, to being in 7th grade at Jackson Prep, taking accelerated math. And for the first several years of that, we were paying all of that out of pocket because we didn't have insurance coverage. Fortunately, with extra work, we were able to do that. And we worried at the time about all the children of the state who weren't able to do that. And even if you look at that just financially, that's going to put burden on the state years down the road for children who were unable to improve and have accomplishments. And then the state ends up having to provide services for them as adults. So we've been very fortunate. We've seen the success of ABA therapy. And not only finances, it takes a lot of hours. My wife quit working when he was 2 and got the diagnosis because she became his chauffeur, his mentor, the one who was pushing for everything to happen, carrying him around to multiple different therapy sites each day so that he could get the appropriate number of hours for benefit. It's been quite an undertaking.
But you can already see what that investment you were able to privately make will now have in his future because of his capacity to take care of himself. You can see that result of that already at this young age. The difference has been, I'm sure, huge.
It's huge. As I say, he's gone from being minimally verbal to participating in regular school with friends and playing football and basketball and taking accelerated math classes. And all this came from ABA therapy and lots of hard work.
All right, thank you. Go ahead. Yeah.
I would just like to say one thing on this also. You know, he had so many opportunities because we did have insurance, but, you know, I've talked to so many people from around the state, and Linda's on the committee also. And we have a Facebook group, fax group, and we communicate with other people from around the state that way. And so many only have Medicaid, and so many of them have been unable to get services. And I personally, it breaks my heart to know that they do not have the same opportunities that that my child has. And I see that those children are never going to improve and never have the opportunities that he has. And they are going to be a burden to the state really for the rest of their lives. They're going to need to be supported by the state because they're not going to be able to hold down a job. They're not going to be able to go to school. And that's something that we have to look at is if these rates do not get increased, and we can't keep our providers here in the state. We're producing those providers. We have those providers that we're producing, but we can't keep them. They're crossing the border into Louisiana, Alabama. Some are going to Georgia. The rates are higher there. And these young people are leaving our state that we're educating. We're paying to educate, and they're leaving. And these people are not getting, and these kids are not going to get the opportunity to get treated. So that's just what I wanted to add, is that we need to keep our providers so that these kids have the same opportunities.
Senator Wiggins has a question.
Yeah, and I'm going to preface it by saying I'm asking for facts, not for you to wade into the politics. But you said you had the Facebook posts and y'all had insurance, but others don't. What have you seen as to why they don't have insurance? And from what I got from your statement, it sounds like because they don't have insurance, their kids are going to be behind.
They are, because they have Medicaid. And there are very few spots for kids with Medicaid. A lot of the different providers don't even take Medicaid at their clinics because the rates are so low. They can't stay afloat. They can't keep their lights on if they take Medicaid.
Okay, so I'm sorry.
Okay.
So why don't, from what you've seen, those parents have private insurance?
Right.
Do you know?
No, they don't.
They
The
don't.
people who go to the clinics have private insurance. Because there is most of them have a certain Blue Cross Blue Shield policy, and there's another insurance that provides, I think it's United Health too. Yeah, that provides ABA therapy. But if you don't have those couple policies that provide ABA therapy, if you have Medicaid, you're not going to find services because there are just a few. And as a matter of fact, there are even clinics that are closing their doors, the ones that took Medicaid, because they weren't able to keep their lights on. There's very few. There's a hand, less than I can have on one hand, of clinics that actually take Medicaid, and they can't take all Medicaid clients because they wouldn't be able to keep their lights on. They have a limited number of Medicaid kids that they can take in their clinic.
What insurance did y'all have? Or
We had Blue Cross Blue Shield State.
the state insurance program?
Right. And you can buy a Blue Cross Blue Shield policy if you don't work for the state that will also provide ABA therapy.
But even that didn't pay our insurance the first few years of therapy, thanks to the legislature. Then finally we had insurance coverage through state of Mississippi. But for the first few years of his therapy, it was all out of pocket.
If I'm not mistaken, I think the lieutenant governor pushed for the state plan to cover autism. So the
Absolutely.
legislature had to get involved. Okay, thank you very much.
Hi, I'm Linda Balfour, and I also am a parent I also have a child on the spectrum, and he was diagnosed when he was 5. So prior to that, he had early intervention. We do have a Blue Cross Blue Shield private plan. That private plan did not have speech thankfully. And the OT was indeed covered, but it was only for 20 visits. So thankfully, we had the ability to pay for our son's early intervention. And we were able to give him, the therapies that he needed. And then he later went to Magnolia Speech School. That cost money. But the issue here with the Blue Cross Blue Shield plan, the private insurance, is that I have a high deductible. It's $5,000 per person.
Sorry, can I ask one more
Yes,
question?
yes, go ahead.
Sorry. Um, do you have what's generally known as a FSA? or
No, we
something
do
like-
not.
Okay. Would that have been beneficial to be, if it's not covered by a policy of some kind, to have an FSA that you can get benefits by paying it through that?
I think, I'm speaking just for my family, that would definitely be extremely helpful, to be able to have that. But unfortunately, our employer does not, my husband's employer does not have that, and many employers do not have a,
Which is why I asked the question.
yes.
Because if they're not being covered under the plans, the FSAs from what I understand, are a good stopgap measure that allows you to do that. So, okay, that you answered my question. Thank you.
Very welcome.
Thank y'all all for this. Thank you for this information. This is critical. This is something that's very close and personal and dear to my heart, as I also have a child who we had to pay out of pocket for because insurance did not cover it. But I don't know where he would be today, where our family would be today, because to say it was life altering is a complete understatement. But I will say this, what is also breaks my heart is the children that were his contemporaries that had no ABA. And the quality of life that they have now and he has is unfortunately very different. So anyway, thank y'all very much. This is something we're going to continue to work on. Chairman Blackwell says he has your information. So thank y'all. All right, we're going to take 5 minutes. If y'all will go ahead and come on up, we're going to take 5 minutes for just a second. Thank you. Yeah, you're. I'm gonna sit back there, just, I'm gonna start sitting. Yeah, I'm gonna just sit down over here. Okay.
How's it going? Got the slide.
Hey, if y'all will come on back. We want to welcome our new Executive Director of Medicaid. We are so excited to have her here with us. And then Dr. Catherine Brett will be testifying too. So welcome. This is your first time before the legislature in your new position, right? It is certainly not your first time before the legislature. So we're glad to have you and we all look forward to
She
working
looks
with you.
thrilled.
Thank you.
Thank you. Good morning. It's a privilege to be here on my 18th day as the Executive Director of Medicaid. Driving better health outcomes for women and children in our state's been a focus of mine for years while managing the state and school employees' health insurance plan. During that time, we've implemented numerous strategies to reduce C-section rates and reduce the number of early deliveries. I'm really excited now to have a much larger team to be working on these issues, and hopefully we can generate even better health outcomes. And I couldn't ask for anyone better to lead these efforts than Dr. Catherine Brett. Dr. Brett is a board certified preventive medicine and women's health expert with over 20 years of experience in the medical field. She is trained in obstetrics and gynecology from at Georgetown University. She also received a preventive medicine and public health degree from the University of South Carolina. Dr. Brett has spent her clinical career working in rural health clinics and FQHCs across the state of Mississippi. So she has a unique knowledge and insight as to the problems that we face in this space. As a skilled clinician and surgeon, she has routinely received patient satisfaction and safety awards during her clinical practice. As a clinical medical director over health informatics for the Mississippi Division of Medicaid, Dr. Brett continues to coordinate clinical outcomes, tracking and reporting. She designs and implements research studies for population health. She evaluates our internal initiatives and our external program performance measures. She also integrates evidence-based health interventions into quality improvement initiatives in the state. So just briefly before we introduce Dr. Brett and y'all get the benefit of hearing her presentation, I just, Senator Boyd asked for just a brief update on our presumptive eligibility for pregnant women. I mean, I think most of y'all know there's a little bit of discussion between us with CMS as we are waiting on their approval. We are continuing to negotiate with them on the program that we're going to roll out to try to shore that up a little bit. As we continue to do that, we wanted to be ready as soon as we do get their approval. And so we have already executed memorandums of understanding with 11 different entities. We have 2 that are currently in the works, and we've already conducted training for over 96 people in the state. And we are currently working with the health department and one other that will add another 100 people to that. So as soon as CMS gives us the approval, we'll be ready to go with the presumptive eligibility.
When is the last time that CMS, y'all had when is the last time that they've reached out to y'all? Like, how long has it been there since y'all had kind of any?
So we actually reached out to them 2 weeks, 3 weeks. 2 or 3 weeks ago, we actually reached out to the head of CMS and asked for his assistance to move this along. And then the following week, we did have a call with them, and I think we're getting real close.
Okay.
So,
all right. Thank you. We look forward to that.
Good. So with that, I'd like to introduce Dr. Brett.
Good morning. How are y'all? I started my OBGYN career in the state, working in rural health clinics and FQHCs, like Ms. Bradshaw said. And after identifying public health challenges in our perinatal population, that what kind of drove me to transition and re-specialize into preventive medicine and public health and come back and work, not in the clinic, but on the administrative and health informatics side for the state. Really looking to leverage our data-driven, evidence-based care and how that can affect our whole system-level impact. So I'm very excited to share with you the work we've been doing at Medicaid to enhance the wellness and improve the outcomes of our perinatal population. Next slide. There we go. I do biological science, not computer science, so be patient with me. This slide is just a high-level overview of our current and future programs and services offered by the Division of Medicaid to our perinatal beneficiaries. This committee is familiar with the implementation of presumptive eligibility, as well as the postpartum extension coverage of 12 months after delivery for our pregnant moms. I'll review later how the division plans to leverage this extended time to improve the quality of health and the safety of our maternal population in Mississippi. So having reached 12 months of claims for the women who received extended pregnancy services 12 months after delivery, the division is in the process now of analyzing this cohort of women to see how utilization of services and what outcomes have been between these women and the women who only had 6 weeks of postpartum care. The family planning waiver provides family planning services and related supports to women and men capable of reproducing between 13 and 44 with an income up to 194%. In addition to the family planning waiver, the division covers 3-month supply of oral contraceptions via pharmacy claims, as well as we cover a 12-month supply of oral contraception when prescriptions are filled at the Department of Health. Targeted case management services are provided via Premise, which is our high-risk pregnant women and infants program and early intervention up to 3 years of age. Both of those programs are administered for us by the Department of Health. Those also include extended services for pregnant women, which include nutrition counseling and behavioral health prevention services. The division expanded telehealth services to allow for virtual visits in our rural communities to improve access to care. We also have our EPSDD program, which is comprehensive and prenatal health service, preventive health services for children under the age of 21. With the increase of our congenital syphilis in our state, the division ensured that policy changes were made so that women could be treated in pregnancy. During a national drug shortage of the only medication that's used to treat syphilis in pregnancy, we pivoted policy to allow for FDA-approved imports. We also are one of only 2 states in the nation that cover point-of-care testing to allow rapid diagnosis and sooner treatment for our beneficiaries. July 1st, we launched a first-of-its-kind Mom's Risk Screen tool and a value-based payment program, which I'll go over in details in just a minute. But these are just a few of the maternal health-focused programs and services at DOM. Later, I will also mention some of the maternal and child health metrics that have been incorporated for providers into our MHAP program, the Hospital QUIP Incentive Program, the MMS MAPS at UMMC program, as well as the incentive withhold with our CCOs. With the new coordinated care procurement, we'll be transitioning to auto-enrollment for our CCOs, which will decrease the time between enrollment in Medicaid and women actually receiving those care management services. Each of our new CCOs have value adds in the contract. Some of those perinatal additions next year will be community health workers, which will specialize in obstetrics care, expanded transportation services to pharmacies, grocery stores, postpartum home visits by nurses, and home health for mothers with wound care issues, as well as provision of car seats. And then at the bottom of the list is, I'm probably too small for you all to read, and I apologize, but group prenatal classes. And so the traditional model that we reference is the centering pregnancy. And so if you're not familiar with that, as opposed to having a weekend class at the end of pregnancy that teaches you how to diaper the baby and breathe, prenatal classes that are group prenatal classes go from the beginning of pregnancy, the entire 9 months, and then even extend into 12 months after. They're regularly scheduled. You're working with a cohort of other women who are educating throughout the entire course. And we really believe that this is a great value add that's going to improve just the health and the wellness and the safety for our moms in the next few years. Next slide. I'm so sorry. I will hold it in my hand and I will remember to push it myself. So I was brought on board in January as the clinical medical director for Medicaid, but prior to that, I served as the state's quality director for our utilization management and quality improvement organization. And one of my main tasks was to help Mississippi Division of Medicaid to really understand what metrics they were being judged by, what factors make up those measurements, and then use validated data to drive programs and policy changes for the state. Through that investigation, I found that many assumptions that are being shared and causes of our maternal health crisis are misunderstood and some are misleading. I want to take this time to share with you factors that are truly driving adverse events in Mississippi based in clinical evidence and driven by validated data. There are some areas where the deck is going to be stacked against us, that we will never raise above 50th in the rankings. But I also want to show you some factors that we believe or have the potential to change maternal health outcomes for Mississippi. With Medicaid responsible to close to 60% of deliveries in Mississippi, there's a critical need to better understand maternal morbidities and their associated risk factors. All women in Mississippi are high risk. So how do we sift out who is the highest risk? Who needs more resources? Who needs that higher touch? Who needs just more? There's a narrative in maternal health, and I've heard that since my obstetric residency, and it's repeated when I was delivering babies at Wayne County and up in the Mound Bayou and the Delta, that if women would just get into prenatal care earlier, we could prevent all of these bad things that are happening and improve our outcomes. But although this is important for overall wellness in a pregnancy, when we talk about preventing bad maternal outcomes or death for Mississippi mothers, our data shown that how many weeks you are when you enter pregnancy is not as important as what's happening those weeks after you deliver your baby. You can see in the most recent 2021 data from the CDC, over 70% of pregnant women in Mississippi had first trimester prenatal care. And actually, Mississippi is doing much better than some of our dark blue neighboring states when it comes to prenatal care. Drilling down into the data, even among our women in the state that had the maternal mortality review, over half of pregnancy-related deaths entered prenatal care in the first trimester. When we look at our national scorecards and state health rankings, the metrics being used matter. Our CCOs consistently receive 5 stars for timely prenatal care in our national HEDIS metrics. However, when we look at mortality rates, our state is consistently in the bottom tier for outcomes. What is driving these metrics? Are they interchangeable? Are they fixable? The Commonwealth Fund and the Kaiser Family Foundation state rankings include unchangeable points that really don't relate directly to maternal health, like road infrastructure or natural resources. Those decks may always be stacked against us. We also hear about Mississippi being a maternal care desert in the news, but what does that really mean? When you look at our state, there's 4 different tiers. So full access, you have more than 2 hospitals or birth centers offering obstetric care. You have more than 60 OB providers and any level of health insurance. Well, for most of our counties, we're never going to have more than 1 hospital. We don't have birth centers in our state. We would love to have 60 OB providers in every county that we have, as well as without women without any health insurance. There are some counties who will always be a maternity care desert. Also, there's an assumption about where the needs are in our state. When we look at this data, counties that are assumed to have poor access to prenatal care actually register as full access as you look at the pink in areas like the Delta on this map here. And so although most of our state is highlighted as low access to care or a care desert, the most recent report from the March of Dimes that was relaying this material also lists that 80% of infants were born to moms who received adequate or adequate plus prenatal care. So there's a discordance in sometimes how these facts are relayed, and what does that really mean for those who are trying to make care? In a separate March of Dimes report, Mississippi receives an F for preterm birth and infant mortality rates, but the US as a whole is a D+. So really on a bell curve, I'm just kidding, but obviously the whole country is not doing well when we talk about maternal care. And looking at the report headline, Mississippi's infant mortality rate has worsened over the last 10 years. Well, if we do a best fit line from 2011, you can see that really there's just normal variance and that it's not that we're getting worse, we're not getting better. And so we do what we've always done. And so the outcomes are what we've always had. And so women are getting adequate care, but the preterm delivery rates, the infant mortality rates are abysmal. So it's this discordance and other maternal health metrics that prompted the vision really to say, what guidance can we give to our Mississippi providers based on the needs and the risks of our population? Which metrics really showcase the root causes of bad outcomes? What metrics can we use to track how well our managed care populations, our hospitals, our providers are utilizing best practices to prevent these bad outcomes? What is our source of truth? And so what's actually driving bad pregnancy outcomes in our state? So the division reviewed 4 years of our Mississippi Medicaid maternal data. We looked at the pregnancy period as well as that 12 months after they delivered. We used adjusted odd ratios at 95% confidence intervals to calculate conditional logistic regression to estimate the association of SMM or severe maternal morbidity and predictor variables in the model. So what are the things that we looked at? So sociodemographic predictors, such as age when the member entered this cohort and their race were included in the model. Social determinants such as marriage status, education level attained, as well as their rural residence. To account for the physical environment of the patient, we took their 5-digit Federal Information Processing System code, or FIPS, for their county of residence, and we mapped that to CDC's Social Vulnerability Index to be able to summarize the socioeconomic status, the disability, transportation, housing, and other conditions in the community. Additionally, food environment is not summarized in that social vulnerability index. So we also use the food environment index from county health rankings for all counties in Mississippi in the year 2018. For care-related and access-related factors, there's several factors that are associated with maternal care, and we included those in the model as well. Pregnancy-related visits in the first trimester, postpartum care visits for those 2 weeks after they delivered were assessed for their association to SMM. The use of both prenatal vitamins, looking at low-dose aspirin among pregnant beneficiaries was also included. Another potential risk factor for maternal outcomes identified by the division's DUR, Drug Utilization Board, was a distance a mother must travel to delivery. And so the distance to delivery center was calculated based on the mom's home zip code and then that zip code for the delivery center to calculate the distances that moms are having to travel in our state for their delivery. We also included in the model clinical characteristics. So the maternal comorbidity index was measured and the association between
Hey, Dr. Brett, can you speak up just a little bit or
I
move the mic down just a
All right,
little bit?
I'll talk
Thanks.
louder and bring this closer to me, sorry. So when I get excited, I start talking faster, so. Yeah, so what the maternal comorbidity, or MCI index, does is it looks at the burden of chronic disease, behavioral health, pregnancy-induced conditions, but it looks at the individual level. And so we use that to develop to kind of predict the occurrence of acute maternal end organ injury and mortality in moms. Also, the CDC has the MMRC, so our Maternal Mortality Review Committee, and they have a list of critical underlying causes of pregnancy-related death. So we reviewed that list, and anything that was not included in our maternal comorbidity index, we also added in the CDC's other diagnosis to really make sure that we threw everything and the kitchen sink into the model to really say what is driving these outcomes in Mississippi. And so when we look at that, only 4 factors were found to be statistically significant in increasing the risk of severe maternal mortality, morbidity, and death in our women. A 100-mile increase in distance from the beneficiary's residence to delivery center was associated with a 12% increase of having an SMM. Black women had a 40% increase. If you were over the age of 35, you were twice as likely to have an SMM than someone who was in the 18 to 24 range. And then when we looked at our maternal comorbidity index as a bivariate, meaning either you have one of these conditions or you don't, it actually showed that having any one of the conditions, there's a list of 21 conditions on this list, increased your risk by twice of having an SMM. And so what do we do with all that data? So we've discovered now what is driving these bad outcomes, what is statistically showing us is causing this, but we wanted to know, when are these events happening? Where are they happening in our state? And so we analyzed our claims for potentially preventable hospital readmissions and emergency room visits and found that 70% of all of our preventable readmissions to the hospital happened after delivery within 6 days of discharge. And then 75% of all potential ER visits, potentially preventable ER visits, happened within 7 days of discharge. Looking back on this slide from earlier, you can see we might be getting 5 stars for our prenatal care, but when we look at our postpartum care, that kind of correlates with our data that we're not doing as well about moms following up in the postpartum period. And so what we did, now that we know what's driving the bad outcomes, when they're occurring, we then harness this potentially preventable admission to say, where are these events happening? And so looking at our claims, most of the returns to the hospital and the postpartum are shown here. So the smaller map is the potentially preventable hospital returns. The larger map is the potential ED visit returns that are preventable. And so you can see the areas where it's lighting up red on the map, that's where it's above expected. Green, they're doing much better than we would have expected them to be. And so drilling into the data, Lincoln and Union County had the 2 highest for being having those preventable returns to the hospital and to the emergency room. When we drilled down into the data even more, when we looked at those visits that are being caused by hypertension or hypertensive disorders of pregnancy, that was Hinds and Hancock County. And when we looked at diabetes and pregnancy, it was Hinds and Lauderdale County. And so there's a lot of resources being deployed by various agencies in Delta countries counties, but there are other counties where a large proportion of the highest risk members are experiencing the worst outcomes. And so these findings have empowered Mississippi Medicaid to actually target interventions towards beneficiaries with the highest SMM risk, facilitating the development of a tailored, comprehensive strategy to enhance maternal health outcomes. Traditionally, quality benchmarks in perinatal care were just on those metrics that I mentioned. HEDIS on when you get into prenatal care in the first trimester. And however, our internal studies prompted just a reevaluation of our quality and our performance metrics to better align with these identified risk factors and to pinpoint who are the cohorts where we can reduce this SMM risk. So starting July 1st of this year, an innovative initiative actually was launched at the division to address 3 M's, which are driving poor health outcomes for our members. And that's maternal health, mental health, and metabolic or chronic health diseases. And so the VBP for maternal health includes the creation of a first of its kind risk score tool for postpartum moms to detect their risk of having an SMM event in the postpartum. And this has been made into the conjunction with this value-based payment program. And so walking through what that means, I'm just going to go over just the maternal health focus today, but our Mississippi outcomes for maternal safety or MOMS risk score involves 2 parts. And so the first part is this risk assessment tool. And so before mom leaves the hospital, this risk assessment tool is going to be completed and it will indicate what mom is. Is she a level 1 risk, a level 2, a level 3? Each of those levels then has an associated indicated time for return. If you're a level 1 high risk mom, we would recommend you having a visit within 5 days of after delivery. If you're in moderate level 2, then within 10 days. And then if you're a level 3, within 30 days of having the delivery. The next part is that timely follow-up. So the hospital is the one receiving that value-based payment for they complete the assessment, it happens. Great, we've identified mom. Now when the provider in the clinic gets mom back within that indicated time frame, they receive a portion of that value-based payment because we completed the loop and got that care. The other portion of that VBP is the care management organizations, and when they are helping to do that coordination of care, the transitioning, ensuring that mom actually has that follow-up, as well as other things that are identified during the risk tool to make sure they're connecting them to those resources identified, they get their portion of that payment. The second part of that is also our cesarean birth rate. And so not just our total birth, out of everybody who delivers who has a C-section, but what we're really drilling down to is the Joint Commission's assessment of our low risk cesarean births. And it's kind of a misnomer because I just said that all women in Mississippi are high risk. So what does it mean if you're low risk for a C-section? And so that's kind of, if you have high blood pressure, if you have diabetes, that's what makes you a high risk person. But what is your risk for having a C-section? So if this is your first time baby, if your baby is head down, if you come in labor and there's not any of these other things going on, your risk statistically should be very low to end up with a C-section. You should be able to have a routine vaginal delivery. So then we look at, so these women who should have been low risk, but ended up with a C-section, how do we look in that data and figure out what's driving those changes? And so those are the second part of our maternal health focus with this value-based incentive program. The other thing that we're looking at as part of this is too, because anytime you drive down the C-section rate, we don't want to reversely increase babies who should have had a C-section not get one. And so we'll also be looking at and using as a surrogate measure babies who are term who go to the NICU to be able to monitor and evaluate to see the impacts of us reducing these low risk C-sections. And so the direct measure for our maternal mortality rate is going to be our 2-week visit, timeliness of prenatal care at the postpartum, and then a surrogate measure for our infant mortality rate is going to be our low risk C-section birth rate at the state. And so Dom ran the data looking at our state fiscal year 2023. And so where our maternity members would have fallen in terms of risk level and follow-up with our mom's risk assessment tool. You can see where those postpartum moms would have fallen, but most importantly, when we looked at the data of moms who had a maternal death during the same time frame. All of our moms who died would have been identified as a level 1 using our risk score tool with an associated potential. There could have been some change in the course of what happened in that pregnancy. So that really made us think we're on the right track and we're looking at that. But the division is continuing to look at data and continuing to refine our tools to make sure that we're being able to provide tailored risk assessment for each mom on that individual level. And then I know, again, sorry for the very tiny type, but this is just all of the different activities that we have with our Moms Initiative, looking at with the hospital responsibilities that they do, the assessment completion, discharge planning. For those level 1 moms, they actually have a warm handoff. It's not just something faxed to a clinic and hopefully it gets to the right place, but someone from the hospital is calling that local clinic to ensure that there's an appointment, ensure they understand why that appointment is important, and making sure that mom gets that transmitted data to that outpatient clinic so they're ready to see the mom in 5 days. Outpatient provider responsibilities to schedule that timeliness to increase their appointment completion rates and other performance monitoring improvement. And with the CCOs, like I said, there'll be performance monitoring when we talk about supporting collaboration, kind of connection to resources, as well as all of those different transportation, just that coordination piece of getting moms in. And then on the division side, we want to make sure we have some responsibilities and some metrics too, that we're being able to be accountable. And so looking at our stakeholder engagement, our communication, and having separate performance and evaluation as far as both the evaluation and payment pieces, and that continually improving to make sure that our risk tool is actually picking up those that we should be. So we're starting in the postpartum time period because that's where the data says we need to start. But we've really looked at how can we envision what this next 10 years of the division is going to look like when we talk about the entire perinatal journey? What does a mom's journey look like through this Moms Initiative? So we're starting with the risk screening tool in the postpartum, but we've been working with our community partners to get feedback. We've been working with members to get feedback, looking at evidence base of what other states are doing with that extension into the 12 months after they've had the delivery. And so we've started kind of mapping out what mom's patient care journey could be and what are opportunities to really improve care. So with presumptive eligibility, with member entry into care, we want to connect mom to a navigator. Currently we use that with care management, but there's options for what that could look like in the future of who that mom's navigator is. But that's someone that connects mom, have you seen your provider yet? Let's get you in. Have you been tested for syphilis and other communicable diseases? Let's get you done earlier than you maybe would have been. Do you have high blood pressure? Do you have diabetes? Let's get you enrolled into other self-monitoring or self-management programs. So that way we're getting mom these resources, getting her into care management sooner than she normally would. And that care manager, it's not just a number that you call if you have problems, but someone who is actively following along, someone that mom knows and is continuing with them through the entire pregnancy course, all the way to when we get to the hospital. We're having now the Moms Initiative that happens, and then again, following them out through 12 months. And so we've been working with many state coalitions to see what are other states doing in this time period. And the short answer is that there's been a lot of federal guidance for the administrative side as far as how to fill out a SPA and what to do. But as far as who needs to be followed, who needs to continue in care management, what programs and services they need, there's still not a lot of data. And so we're using our own data and talking with other states, to see what they're thinking, to really try to craft what this postpartum program is going to look like over the next few years. But this is kind of our idealized of what that mom's graphic journey, so that it becomes a person-centered, evidence-based, data-driven care model for mom. And lastly, to develop those programs, we need to know where we're starting at and to use evidence-based data to set quality benchmarks and performance metrics for our partners. And so we'll track how well our managed care organizations, hospitals, providers are utilizing best practices to prevent bad outcomes in our members, but also use that data collected to educate our members, to develop scorecards that they can be able to have a choice in choosing their care and being able to optimize that best care team for them. We'll use this data to model future projects, continue to refine and indicate for our tailored risk score tool, but as well as to establish evidence-based protocols and implement strategies to enhance our maternal care plan, hospitals, and provider accountability for these maternal morbidity and drive evidence-based high-quality perinatal care that will lead to improved maternal health outcomes. And so I'm going to just read a few of these since it's so tiny print, but I already mentioned our low risk cesarean delivery rate, severe obstetric complications, perinatal depression screening, but not just yes or no, do you have it, but the follow-up piece. What happened in that 30 days after? What specific resources were moms connected to? The timeliness of postpartum care, low birth weight, preterm birth rate, our term NICU admission rate, but also just our total NICU admission rate. What is driving these high cost care episodes, and can they be prevented? ED utilization among our postpartum beneficiaries, outpatient visit utilization in our beneficiaries, contraception, screening for perinatal mood and anxiety disorders, screening for tobacco use. But again, that follow-up piece, what's happening after that? Yes, you have this. What resources are you using? What kind of medication therapy management? What kind of cognitive behavioral therapy? All of those things that combine for that total care, not just screening yes or no. Health-related social needs, mental health prevalence, and the utilization of services, as well as adherence to evidence-based care. Hypertension, diabetes disorders, as well as, hopefully the congenital syphilis will be the only STI prevalence that we have with our members, and we'll be able to not have extra, but we'll be continuing to surveillance that throughout our entire population and look at utilization of services, but also where we need to deploy that high quality care. So again, this is just a very high level, quick and dirty of who's getting kind of looked at for what. But it's just a small sample of how we're really enveloping quality and evidence-based and data-driven into all of the programs that we have at the division. And so some of the things that we listed out of how we looked for our maternal health, we're also going to be looking at that in our mental health population, as well as our metabolic or chronic disease for the other portions of our value-based payment program. So I definitely want to thank you for just an opportunity to share just a small portion of what we're doing and how to ensure that our perinatal populations don't just survive, but they actually thrive during the course of their pregnancy. So thank you.
Thank you very much. I'm going to start off and let Senator Hickman, he's got a few questions.
Good morning, and thank you for all the work that you're doing. Some of the things, I just got a couple of questions. I may ask something that you answered, but I think you're kind of like me in that when you know something and when you're trying to get the information out, you speed up, and then it was a little bit hard to hear. So my first request is, will we be able to get this slide presentation?
We sent them over on Friday to.
Okay, perfect. My next question is, I know that you spend a lot of time, like the mom program. I think it's amazing to make it data-driven and individualized for mothers. I know you spend a lot of time, and the majority of that, if I'm understanding correctly, is postpartum, because that's where you've identified most of the problems. But I think when you showed us the line of pregnancy, there was also some ability to grab mothers during the pregnancy or prenatal and like follow them along. Can you explain that portion a little bit more?
Correct. So it's kind of phase one of our Moms Initiative as we're starting in the postpartum period. And so it kind of is when you hit delivery, you're at that hospital is when that initiative is starting now. And that's where the risk screening tool is happening. We're getting you transitioned into the outpatient care to make sure that we get you back in sooner. But the next phase is how do we continue to use data to develop a prenatal? Because right now we were looking at just things that are in the model are, did you have a C-section or not? What happened during the delivery? And so to be able to look on the prenatal side, it's not that that couldn't be applicable as well, because a lot of those factors, do you have high blood pressure? Do you have twins? There's things that would be universal, but we want to look at the data to make sure that when we shift it to that prenatal side, that it's still technically, statistically significant for what we're using. And so we're starting there because that's kind of how the model, it showed us that's where the highest risk and the things are happening right now. But our goal is to do that throughout the whole pregnancy. And maybe then the phase 5, phase 10, I sound like a Marvel, producer, but even before, we have a family planning program. Could we be able to use some kind of tool in the beginning to be able to do risk score or, computer generated, risk identification to be able to give more education and be able to improve our family planning before someone even gets pregnant. So those are kind of those long-term things that we're envisioning. But yes, our ultimate goal is to take that same risk score tool and to get it in pregnancy. And so there's not a reason that providers now couldn't start using it in the beginning part. All right, you have this, because they should be doing, depression screening. They should be doing intimate partner violence. They should be measuring weights and seeing if someone's obese. They should be talking about, where do you plan to deliver? And I already know you're going to deliver 100 miles from here. You're high risk, and go ahead and let's put plans in place before we have to get an ambulance in the middle of the night. So that's kind of our phase 2 is to move it backwards into that prenatal period.
Okay, and then just finally, I think I'm gonna ask you a couple of questions in one. But I guess where are we on the program in its entirety? And then what are we looking at as far as time or phases? And then finally, I'm guessing in phase 2 or 3 or whatever, is there a part where we look at a mother's, I guess, prior pregnancy and determine what kind of assistance she's going to need if she becomes pregnant again, or when perhaps that mother becomes pregnant again? And does that maybe pre-qualify them for the whole pregnancy journey if they had a high risk or difficulty in their last pregnancy?
And repeat just the first part because my idea.
First part was
the
about
second
phases
part.
and
The
timelines.
phasing,
Like,
yes.
where are we and what's the timeline?
So this is year one. So July 1st is when implementation started. And so this is the technology side of the part. We have the risk score tool. We've been presenting to several hospitals that use Epic. We've also been going to smaller hospitals that don't have access to Epic to say, how does this look like? What is the workflow for first integrating this risk screen into your hospital? How do we digitize this? How do we get this into the EHR? How do we get this into workflows? That's kind of step one that we've had that. Now it's in the workflows. How does that get transmitted to the provider? And so we're in that technology phase right now of figuring out where those nuts and bolts are. The plan right now is that the hospitals will do ADT alerts to be able to send that information to the providers. And then we'll couple that with the warm handoffs to be able to get some of that other information to the provider clinics. The next phase of that, and that's we said, this is how we're sending the data out, is working with our provider groups. How are you receiving the data? Who in your clinic is receiving the data? So that's why this first year is really a paid for reporting. If you're doing your meeting with us, you're working to get everything set up, our plan is that by next July, we'll be able to go live with this program. Beforehand, great, but because of all the steps and figuring out how to be, simplified and to be that every hospital is doing it the same, every clinic process is doing the same, there's a lot of steps to figure out just that technology piece of it. But right now we're kind of halfway through that first year. And so our plan is by July 1 to start the actual implementation of the program.
It should be just so when do you predict we will see maybe, or if you know, when we would see an improvement in our maternal health?
Right. I would hope within that first year, because if we're not saying that this is the golden, the magic ticket, and every time somebody's a level 1, we're going to prevent everything that happens. There are car accidents. There are things that are uncontrollable that happen in the course of pregnancy, but we are introducing that potential because in traditional practice, it's been changing, but you don't see someone back if they have a routine vaginal delivery. We'll see you back in 6 weeks. Call us if you have any problems. Well, that's a long time for things to go wrong. If we even look at just the HEDIS measure that we are judged by, do they have a visit within the first 84 days? You get a gold scar as long as someone's seen within that first 84 days. A lot of bad things can happen very quickly in 84 days. And so that's our intention with this program for those that are high risk, that they're getting in sooner. So that way, instead of coming in the middle of the night with a preeclampsia process, you've been seen, we notice that your blood pressure is elevated. We have a chance to educate you on all of the symptoms that need to come back. We have the care management. We have the mom's navigator that knows that you're high risk. So she's checking up on you more, so that we're introducing in this risk, this chance that we're decreasing that risk of something bad happening, that someone's looking at you, someone's contacting you, you're going to get in sooner before we have these severe events happening. So I would foresee to see numbers change within that first year. Now, to see a statistically significant improvement, we're talking 3 or 4 years to get big enough cohorts to have that data. But I envision that this is going to make major changes because it's something that's not done. All practitioners each have their own kind of how they do things, every hospital, every clinic. And so this is helping to do a little bit of standardization for our high-risk moms, that everybody is getting the same evaluation that is tailored to them, but they're all getting an evaluation and a risk screen before they leave the hospital, so we know what they're going home to. Yeah.
Senator Braun?
You had a slide showing maternal health deserts, I think. Can you put that back up, or is that possible?
They've taken it off, but they should be able to.
Do you have a handout or anything that has? I can't hear words you're saying. But I mean, I don't know how this works. And of course, we've got all these machines and everything. What we don't have are microphones and loudspeakers. But somewhere, yeah.
This slide, sir?
And of course, what happens is there's some computer program that takes these slides and then reduces them down so they fit on these pages. And when they do that, the type's so small, you can't read it. But at any rate, looking at the maternal care desert, it looks to me like an awful lot of the Delta is showing up with full access.
Yes.
And I think that I'm told there are just very, very few actual OBGYNs practicing in the Delta. And I don't know how many hospitals offer OBGYN care and offer deliveries or whatever the term is, when in fact, the real availability of someone there to deliver babies 24/7 is more theoretical than real. And I guess one of the questions I'm asking is the data and how we come up with this may produce an odd result.
And that's why that's some of the slides before this and the slide after was kind of to show that discordance, that we would not expect to see our Delta counties as being full access. I would have assumed before I read the chart that pink meant that that was where you had the lowest access. And so that's why we put this slide, because there's discordance in what we expect and what we see, and why we wanted to do that deep dive in our data to really see where this is going on. Because HRSA is the one who funds this and makes those definitions. And so for a maternity care desert definition, you have no hospital or birth center, you have no OB providers, you have any woman who's 18 to 64 without health insurance. And if you have anyone, if you don't meet all of those criteria for the upper three, then you're labeled a maternity care desert. So for the full access, though, you have, you can have some of those things. So if you have at least one hospital or a hospital and a birth center, if you have, but you don't have the 60 OBs, or you have any level of health insurance. So it's hard to know exactly how these counties are going in and who's selecting these definitions. And so that's the point of this slide, is that we hear a lot about this maternal care desert, and it's being used to quantify things, but they don't jive with other data that we know or other data that we look at. They're reported by the same, the CDC, and with the March of Dimes, they have this. And when you turn the page over, they then say that 80% of infants had adequate prenatal care. Well, if we're in a prenatal care desert, then how did we have adequate prenatal care? And so it's understanding what those definitions are, what's making up those metrics. And because they are confusing and sometimes conflicting, that's why the data that the division is looking at is our own data, because we can define what we're looking at, what those definitions are, and really just throw everything into model that we're saying, I'm not making assumptions. I'm not thinking that it's going to be the Delta, but I'm going to throw everything in the model to say what really is driving bad care in our state.
Well, all I'll say is that it shows, as best I can read this slide, that I think you're in a desert if you're in Itawamba County. And while there may not be services in Itawamba County, you're adjacent to both Amory and Tupelo, both of whom have rather large OBGYN facilities available at the hospital. And Prentiss County shows that it's a desert when there's Corinth and New Albany and Tupelo all around Prentiss County, which have robust OBGYN programs at the hospitals. So I don't want to belabor the point, but the slide looks counterintuitive to me. And I'm not sure that I believe that my intuition is wrong and the slide's right.
Well, and you're 100% correct, sir. That's one of the data that's out there that's misleading.
Just stop right there. That's all you need to say. Go back to the part about my being 100% correct.
All right. That's all. The presentation is over now. We're done.
That will be taken out of context many, many times. No, thank you. I don't want to belabor the point. I'm just saying that there's a lot going on. Thank you.
But you're right, it was an example of that's misleading, and that the slide, the data in and of itself doesn't map what we know for what we know about our state. And so some of these nationally produced store cards, state rankings, maybe not actually reflect what Mississippi is really doing and those services that we're providing to our members.
Additional questions, Senator Bryan? Okay. I've got a couple of questions. Oh, I'm sorry, Senator Wiggins, go ahead. I'll finish up. Sorry.
Let's go to the slide of the 4 data point, the 4 ones that y'all are looking at. The, okay. Which I found very interesting. If I, on the inherent risk, so if I read that right, well, if I read all of them right, so you're saying inherent risk is 200% responsible for severe maternal morbidity?
So in that inherent risk, all the things that we looked at, so that's why we put inherent risk there for that category of what we looked at, specifically for the maternal comorbidity index. And it's a list of 21 conditions. So if you have one of those on the list, your risk is 200% of having a bad event.
Okay. My assumption would be it'd be like diabetes, high blood pressure, things like that.
There are those on there, but there's other things like uncontrolled asthma that you look at, well, how is that related? But it's being tied to end organ damage and things that happen in pregnancy that cause those severe events. So these are got those precursor conditions that you could be able to look at the antepartum period, because some of those women will have had beforehand. But other things on the list are, having had a previous section, having a current C-section, things that are going to change your metabolic profile, things that are going to change your chemistry in the moment while you're pregnant, and are going to lead to some acute organ things. And so having any one of those on the list, whether even just having the asthma, that is increasing your risk. And so we look at, these are population level, and so that's where we do that score tool to be able to take something like asthma, but be able to put it in concert with how far were you from pregnancy, what is your race, what is your age, do you have anything else on that list that then is going to aggravate that and multiply those numbers to calculate what your level of risk is. So if I have asthma, that's a high risk list, but maybe that only makes me be a tier 1 if I have nothing else that's on that list, and everything else is perfectly happy in pregnancy. I'm controlled. I have any events during the pregnancy. That might be my individual risk of being moderate or low risk, versus someone who has asthma, but is also a Black woman who's 36 and is going to be delivering 2 hours away. Her risk is going to be a level 1 when we add in all those factors together to get that risk score tool for her.
Okay, and then to somewhat of Senator Bryan's point, the top one there, we always hear about access, lack of access. If I read that, that's saying, quote, only 12% is lack of access to that causes this.
So part of that is as access for when, like we have our level of, if there's a baby who's born after a certain amount or before a certain amount of weeks, that they have to go to Forest General or a level 4 center like UMC. So some of that we cannot change, and are currently looking at how to be able to parse some of that data out by looking at ambulance visits versus drive. But especially where I worked in the Pine Belt and, in other rural communities, there's a lot that goes into pregnancy choice. There's some prestige for delivering at certain hospitals. And so there are some members who choose to deliver at other hospitals and are choosing to take on that distance. So it's being able to ferret out, those that are having to travel the 100 miles because they don't have access, versus they're traveling that from a choice, or that's where their doctor moved to and they want to go deliver with that, that person delivered the other 5 of their babies, so they're going to go to that member. But now that increases their risk, because in the middle of the night, if you're driving 100 miles by yourself in a car, that's a lot of miles for something bad to happen. And also, when you get to that center, they might not have your prenatal care, or vice versa. You had your delivery here, but you go back to finish, do your postpartum care with your provider. They don't know what happened. And so that's part of knowing this 100 miles. It's not that we're going to change that, but to know that that's a risk. And so for these members who have traveled 100 miles before they leave the hospital, we make sure that their home clinic has this information.
Okay, and so now that y'all have identified those 4, what is the strategy to do what I call bend the curve, that now that you've identified it, to get that, the rates of severe maternal morbidity down?
Right.
What, and does that require legislative, bills and so forth?
At this stage, don't quote me because I do the clinical side, so I will defer to this wonderful team behind me when it comes to the political side of what needs to do in legislative. But at this stage, no, because how we're utilizing this data was, number one, we created our mom's risk score tool. So these data points, we also took data from our state's MMRC, so that's Maternal Mortality Review Report, and so those top 5 causes of mortality-related deaths. So things like obesity was number 1 for being related to the cause of death. 4 of the next 5 were
Right.
mental health. So we put all those things into this risk score tool, and that tool is what's going to help with the maternal rate because we're identifying women. We're also going to take these 4 things and make sure that as we get our new CCO contract, that they're highlighting these things in the contract when we're doing their initial risk assessments at the beginning of the pregnancy, that they know this. They're asking that question, well, where are you delivering at? And that way they're getting kind of tagged that you're a high risk member. We need to follow you along. We need to make sure we're getting resources to you. We need to make sure we're getting education to you because you're high risk all the way along throughout the pregnancy. So hopefully that's in the short term, that's how we see this data directly translated into improved maternal health.
All right, I've got a few questions in here. When we had hearings a couple of years ago, one of the things that kept consistently being brought up by medical professionals was birth spacing. Is that in one of those inherent risks if you've had a child within the last 12 months or anything like that?
It's not it was part of the initial model that we looked at was how many pregnancies total you had, how far apart they were. We did
Right.
look at that, but it wasn't statistically significant. So we
Okay.
took that out of the model. So it's clinically relevant, and that's for the provider and the mom to have those, those risk benefit conversations about that, how to space those pregnancy. But as far as specifically for our risk score tool, it's not in there.
Okay. Additionally to the legislature passed 2 years ago, postpartum, where we extended care the full 12 months because of the issues that you've identified in here. When will we have available early utilization rates for the first full year of that program? When do y'all expect to kind of have some utilization rates on that?
Right. My goal would be to have that before, I would hope to say before the next legislative session to be able to give that information for you all to make decisions. But right now we're in the process of getting that data. And so being able to make sure that when we're pulling data, we're using the right definition. So if I pull you as a member of this cohort, that it's correct. And so that's what the time that we've been working on right now. But our goal is to, initially it was December, but we had some technology things that don't talk to each other, and we had to figure out how to get that data to the spot to talk to each other. So our plan was to have it by the end of the year, but I hope by the time we get into that legislative session, we at least have some data points. And so if there are specific things that would be helpful, we can prioritize those things to get that information for you.
Yeah, I think we've all seen through the number of years, we're really good at passing legislation, but then sometimes we don't take advantage of the programs that we actually have out there. So I think that's why we're interested to see about that. Additionally, too, I'm very pleased to see that we're using community health workers in this model because we know that a number of other states have found success with that. Tell us what you see the community health workers doing in the obstetrics area.
Well, and we're in the process of working out with the CCOs exactly what does that mean? Where will they be deployed? Will it be system-wide versus taking our data and doing it in some of these counties where the highest risk? But the biggest utilization that I feel for on the division side is to be able to enhance what our data is. Because if you look for national data, if you look for our statewide data for how well do things work in Mississippi, we don't have that. So in our CCOs, adding that to a portion of the new procurement, we can be able to get those data, set metrics, and really be able to harness how well is this working, and then be able to deploy those into other areas in the state.
Will they be a navigator though for those women for maternal health issues? Will they be helping those women navigate to make sure that they know they're going to the right places and getting the help that they need through both during pregnancy and postpartum? Will they be used for that purpose?
That is the intention for that. And so
I look forward to seeing the results on that. This is a question not necessarily for you, but maybe for Director Bradshaw and Senator Bryan, I think it's something that you have asked on a number of occasions in the past. You have different issues here as it comes to mental health, as it comes to issues maybe that the health department is. Do we have a statewide that we have multiple agencies, a plan? Y'all are doing a great job with what y'all are working on, but do we have a statewide plan on this that involves multiple agencies and that the different agencies have different pieces and parts of this?
We do work with other departments, we work with the health department, we work with mental health, and that is something that we've had discussions about just recently, it's just the last 2 weeks as to how we can pull in different agencies from continuity of care, in addition to funding sources. I think there may be other agencies that are using state funds that perhaps federal dollars may be available for if we, connect with those.
Okay, that's just something, we've had additional conversations this fall and things like that. So I know it's something Senator Bryan has been asking for a number of years, that we maybe have some cohesion with our different state partners, and maybe a plan on that. So anyway, thank y'all very much for coming today. I had a text from one of the committee members. You're expecting to know from CMS roughly, you hope to hear back within the next week or two, couple of weeks?
I think it'll probably be within the next 2 weeks.
Do you expect us at this point to have to redo legislation on that, on presumptive eligibility? Do you have an answer to that yet? And I'm not going to hold you to it, but do you? You're unsure at this time? Would that be?
Well, I think we can come to a reasonable place that we will be able to get it. Am I 100% comfortable with that? No, I would prefer that we have legislation to shore up the concessions that we've had to make.
Okay, thank you very much. Thank y'all very much for coming today. So. Dr. Edney? Dr. Edney? We're starting to. Dr. Edney? We'll go ahead and start if you're okay with that, so. Dr. Edney, we have people listening by Zoom. So anyway. So I see he's putting his picture in right there. Good breath. Yeah, thank you. We're going to start back. Dr. Edney is here as our state health officer, and he is going to give us the health of the state. So that's going to be, we are ready to hear that. So thank you.
Thank you. Such as currently working a salmonella outbreak related to a restaurant that actually was a significant outbreak, and protecting the public there. And the last thing I did as I left the office to come here was to give orders to work a whooping cough case that, as those numbers continue to go up. So we have challenges across the board, but this is a particularly important area of public health. And what I've done for you is to modify my report for the state of health for the state and focusing on women, infant, and children. We always appreciate the opportunity to share with you what we're seeing, what we're working on, and also to try to give thoughtful advice of where we need to go together as a state. I have shown you this Commonwealth Fund Public Health Report Card for the state. It is remaining the same, although we do have some public health indicators that are showing some improvement. We still have enough challenges that we are lagging behind all of our sister states. And what I always like to point out with this slide, I think you can see quite easily where we rank as a state, all the way to the right and to the bottom. And what most people are not aware is that we're not just talking about poor health of minority communities, we're talking about poor health for the entire state. If you look at our score, we are ranking below the all group median for all of our populations, the majority Caucasian, the largest minority population being African American, but Hispanics, Native Americans, Vietnamese, all of us are underwater, and by a significant amount. And my goal as your state health officer is to lead us at the agency with strategic investment of resources towards eliminating not only the health disparity between the populations within our state, as you see the separation between those two dots, that just all the health disparity is picking two populations, and you can pick, blue-eyed blondes versus red-headed green eyes if you want. But if you look at the majority Caucasian population versus our minority populations, there's a large split, which shows a very significant difference in outcomes of health between those populations. But what I also point out is the disparity between Mississippi and New Jersey, or even Mississippi and South Carolina, Mississippi and Alabama, Mississippi and Tennessee, Kentucky. There's a large separation between the scores of our entire population versus their entire population. So it's an important issue within the state, but it's also an important issue that we just are not living as long as everyone else. We're dying of preventable causes at the highest rate in the country, which means the people that all of us are working hard to serve are dying unnecessarily at a higher rate than anywhere else in the country. And these are all fixable issues. This is not just who we have to be. And so as the most recent ranking for this is specifically for women, infant, and children, when you look at all-cause mortality for women and babies, you show that we rank, 51st. We even have, Puerto Rico ahead of us. I'm very serious when I say the only reason we're holding 50th is because there's not more states to push us lower. But I do believe we're beginning to close that gap, and we are working very hard to do it. Ranking number 12 in the Southeast really doesn't, it just shows that within Region 4, we're all the states that are very similar to us, that we are at the back of the pack, and significantly so. We're ranking 43rd related to coverage and access and affordability. And that access piece is a big piece that's holding us back. Healthcare quality and prevention. I would stack the quality of our healthcare against anyone. Access to it is difficult, and access to preventive services is literally killing us. And so prevention, we score very, very low. Even those who have access to preventive services aren't doing a good job to do that. So we have a lot of opportunity here. We do well in HIV, which I'm very proud of at the health department. We are reducing HIV rates. Our prevalence grows because we're treating it very effectively, and they live a normal lifespan now, patients living with HIV. But we are reducing the new case rates. We score very well when you look at uninsured women during pregnancy, because we're doing well with Medicaid. And our maternal mortality review committee findings are showing we're still running about 65% of our births are Medicaid births. And our women who have access are smart. If our women have access, they're taking advantage of it. That's a great score. So as we improve access, I think we'll see a lot of these indicators for women continue to improve. We're doing very poorly with our older folks getting their flu and pneumonia shots. We remain at the bottom with infant mortality, but I have some encouraging news to show you there. The thing that worries me is scoring so poorly with preterm birth. And preterm births are driving infant mortality. It's the number one cause of infant mortality, 0 to 12 months in Mississippi. And I was visiting with my colleague, Dr. Scott Harris in Alabama. Their number one cause of infant death is genetic. That's what we want. We want our number one cause to be genetic and not preterm birth and not unexplained sudden infant death. So, but I do have some encouraging data to show you there. This is not encouraging whatsoever. As I been digging in with more granularity into our population health outcome scores. The first thing I asked was, how expensive is this? How expensive is it to be ranking so poorly with so many of our health indicators, and certainly with women, infant, and children? And so we commissioned a study with an independent health economist to look at the 3 leading causes of death: heart disease, malignancies, accidents, and we added maternal infant death because of the importance of it, which is germane for today. And that number is about $25 billion a year that's lost to the economy. Those are real dollars that are not in our economy at work because of the impact of poor health. And then I went more granular with it and specifically looked at maternal infant death specifically as a cost. And the fact that we have such a high rate of maternal and infant death is costing us right around $3 billion a year. And that's year after year after year. Now, this isn't cost to healthcare. This is cost to the economy. This is lost productivity, lost workforce, disability payments. I mean, you name it. And we have the methodology to back up those findings. But the point of this is that poor health is expensive. It's expensive to healthcare, but it's expensive to all of us. It's expensive to the taxpayer, but it's expensive to Mississippians who want a healthier economy. And so here is some low-hanging fruit for us. The next question I asked, well, all right, so we're talking $25 billion a year negative impact for those 4 causes. What's the impact to the population? What should the population of Mississippi be? We're about 2.9 million. If we were average with our mortality rates, how many people would be alive that are not alive today? So we calculated that. We went back to 1950 and moved forward year by year for all-cause mortality, meaning looking at all causes of death at all ages. And we ranked ourselves to the U.S. all-cause mortality rate. So the blue dots at the top are Mississippi. The green dots at the bottom are United States. I would point out to you that the 1950s and 1960s to the left, we were not at the U.S. average in those years. That is insufficient reporting. Our reporting was not robust enough then, but you move forward, and as you get into the 1970s, 80s, certainly the 90s, that is very solid data. And I would point out to you, please look at the pattern, because I was not expecting to see this. And it was shocking to me when I was shown this. I really thought our mortality, all-cause mortality rates would be flat, but not improving. But what we're seeing is through 2019, steady increase in mortality from all causes, and very worrisome, the split between us and the US average is growing. And then we hit the COVID years of 2020, 2021, 2022, and our mortality rate went out the roof. I'm anxious to see 2023's data to see where the reset is going to be. And probably this year will tell the tale where we are. I'm optimistic that we should be lower than 2019. I'm praying that we're lower than 2019 to show that we're getting some traction on working this area. But I have visited with my colleagues in Oklahoma, Louisiana, and Alabama about this data. They had not looked at this yet, and I challenged them to do it. I wanted to see what their pattern is looking like. Are we an outlier? Is this, the states much like ourselves looking the same? I expect our numbers will be worse, but I'll just be honest, I was not expecting a steady escalation and the disparity widening. You'll see the US mortality rate going up as well to 2019. That's the opioid epidemic. And that's why our life expectancy as a nation has been going down. And so that's, we do know part of our escalation was the opioid epidemic. Last 2 years, we have reduced opioid deaths in Mississippi. So I'm hopeful that that's going to show improvement for the 2023, 2024 data. One thing we're doing at the Department of Health is studying this phenomenon so that we can explain this in better detail to y'all as you're making decisions. But as you're making healthcare policy, please keep this in mind. Please refer to this data. This data is of extreme importance. The number calculated, just the raw number, the lowest conservative number, is that if the blue dots equaled the green dots across the board, there would be 215,000 people alive today that are not alive. And this is not potential, this is real lives. I can't say that they'd still be in Mississippi. They may have well moved to Alabama if they had lived, but because where we are with mortality, they did not survive. And that's 215,000 Mississippians. When you factor in the fact that the 1950s and 1960s were worse than what we're showing you, and then if we factor in the fact this is showing infant deaths and childhood deaths and young people deaths before they have a chance to have a family, we're getting closer to 400,000 people. And I will let that marinate a little bit. 400,000 people who are not alive. Some have never had a chance to exist because it was related to an infant death that never had a chance to reproduce. But a lot of these deaths are very preventable deaths. A large number of those baby deaths are preventable, maternal deaths are preventable. And as I show you our leading causes of mortality, we're going to show you that these are largely preventable. Why do I show this for women, infants, and children testimony? Is because a large number of these are women, infant, and children. All right, and I have this for you in your packet. I'm not going to go into a lot of detail. I would ask you to look at the COVID years, and please notice the much higher mortality rate in Mississippi than the US average. But as you go through, we actually have for you the numbers with looking at actual Mississippi death counts through all those years. All right, so the three leading causes of death in Mississippi remain heart disease, malignancies, and accidents, and that remains true for women. For children, accidents is the leading cause. For infants, the leading cause, as I told you, is preterm birth. But as we look at heart disease and malignancy, there's only so much that as a Department of Health we can do about this. We work hard in this space with public health programming. We don't have a lot of federal money directed at chronic illnesses. We use a good bit of our own discretionary money to invest in reduce mortality rates with heart disease and cancers. We have to do much more work in accidents, and I think you will see, I'm hoping to announce at the January Board of Health meeting, really our thoughtful strategy for going after accidents at all ages. But as we improve accident rates, then that will be a significant number of children who will stop dying. I do want you to understand as a physician that to impact heart disease, we have to impact lifestyle, and we also have to have access to screening. And at the health department, we are doing the Know Your Numbers program, as I've shared with y'all, where anybody in Mississippi can go to any health department and get a free blood sugar and blood pressure check. And y'all would not, you can only imagine what we're finding. And as we identify a lot of young people, with diabetes, undiagnosed, hypertension, undiagnosed. We get them into a medical home to the best of our ability and make sure that they're cared for. Same thing is true with malignancies. We are scoring very poorly with our screening exams. The large number of these deaths are preventable. These are breast cancer deaths that are being diagnosed too late, colon cancer deaths being diagnosed too late that should have been prevented. You know, colon cancer is a preventable illness when you have access to screening starting at age 45. But we have to have, and lung cancer screening is very effective now, but you have to have access to low-dose CT. And unfortunately, the only program we have to facilitate screening is our breast and cervical cancer program, which I'm very proud of, is to give all women access to mammography and to pap smears in the state. Another data point that is important for you as you're making healthcare policy decisions, this takes a bit to get your mind around, but if I take you back and and identify the number of infants in a year who died between 0 to 12 months, then our life expectancy, and I'm going to show you that data in just a little bit, which it's gotten worse. Our life expectancy being around 73 years now. The difference between a 6-month-old dying from co-sleeping to 73, those are potential years of life lost. Does this make sense? And then, and you add that up for every death in Mississippi. And so for every death below our life expectancy, those are years of potential life lost. They're not actual years, but they're potential years. And when you look at heart disease, accidents, malignancies, that makes up about 200,000 years of potential life lost every year, which drives us to those very real low population numbers. I mean, y'all do realize we could have a 5th congressional district if we just had average health, not super great health, just average. That's 300,000 to 400,000 people that are in the population. So that 200,000 years of potential life loss is a very big deal to me. It's one of the metrics that I'm monitoring. I'm anxiously waiting. Our annual report will be on time. And I'm anxiously waiting to review the 2023 data compared to the 2022 data. This is 2022 data. And this is one issue that I'm watching closely. And those of you who also serve on public health, this is what we're going to be really concentrating on. This is another scorecard related to women, infant, and children. This is America's Health Rankings, another reputable public health scorecard, and had some positives and our usual negatives showing up. I'm very proud of the fact that breastfeeding initiation rates are going up. We need that. That helps us have healthier babies. I'm very excited to see that the poverty rate as scored for women and children has gone down. That's still a lot of opportunity, but that is wonderful news. Firearm deaths have gone up, and firearm deaths are our leading cause of death for children, just accidental discharge. And as I shared with y'all last year, there's good public health policy that does not involve gun control that really impacts that number that we have to start leaning into, that I'll be sharing with y'all probably when we're in session. Injury deaths continue to go up, and getting our arms around accidents is extremely important. That includes overdoses, which we have more people surviving overdoses now. That's an accidental death. Drownings, which is a significant cause of death for children. Strangulation, suffocation of babies that are co-sleeping, with parents or grandparents, that's an accidental death. Tammy, I would include unexplained sudden infant death is really many times accidental if they're being put down on their stomach instead of their back. So some of this is low hanging fruit. Motor vehicle accidents where the baby or the child is unrestrained. And yes, we do see that. So we will be working diligently in that space as I cultivate the funding for that. I did want to show you a strength. We do have a low prevalence of excessive drinking among women. That is extremely helpful. Our homeless rate is low, thank goodness. Challenges remain our mortality rates for infant and children, percentage of children in poverty, and high prevalence of physical inactivity among women, but I would say children as well. And that I had this for your information, a little bit more granular detail, some of the breakdown. This slide shows many of the social determinants of health that are truly impactful with our negative health outcomes. As I have said many times, access is a complicated issue. You have to have insurance to have access. You got to have a ticket to ride, but even having that ticket is not sufficient. It's necessary, but not sufficient. Many of these things that I have listed out for you and where our state rankings are extremely important. And I would make sure that, to point out housing and transportation. Y'all know y'all hear that every time you turn around. But it is a very, very real issue in the state, the difficulty with transportation. And I am proud of our Transportation for Health program, where at least we were able to pay for folks to come to and from the health departments. And we're studying that data. Won't be bringing it to you this year, but as we continue to look at that data, we're looking at the folks who are requesting rides somewhere else, and these are the uninsured. This is not Medicaid transport. This is basically providing a taxi ride for someone that doesn't have a way to access public health. But we get calls all the time. Can you take me to UMC? Can you take me to my doctor? And we're not able to do that with our grant funding, but we're tracking that data. Madam Chairman, I'm happy to entertain questions as we go. I know I'm throwing a lot at you. Very happy to stop and at any point that y'all have questions.
Just very quickly, on the transportation, how much or do we have data showing how much that's improved people actually showing up for appointments and the amount of people that we're able to treat and care for?
Yes, for the clinical care at the health departments, we can show that to you. We started off with an extremely high no-show rate, and a large part of that, and that was with us calling, the evening before, are you keeping your appointment? Yes, I'm coming, and then no-show. With the Transportation for Health program, whenever someone makes an appointment at the health department, first question they're asked is, do you have a ride? And if they don't have a ride, then we facilitate their transportation to the health department, then to the pharmacy if they need to go to the pharmacy, and then home. And, those numbers are steadily increasing, and the Uber driver numbers are steadily increasing around the state. Little economic development, so the more folks getting that job. And we actually set the contract so that other state agencies could piggyback and not have to go through the procurement problem we had to go through. So I serve on the Department of Rehabilitation Services Board. Transportation is a big issue with the people that they serve. This is a common issue. So our little program is making a difference in our little world. And I'm really wanting to study our data so that we can look at where else would it make sense.
The exact point that I was trying to get to. So whenever you look at that, we love to hear an update on that.
Absolutely. Thank you. And there are a few areas where our rankings are fairly good, and some where they're better than they were. And I preach all the time at the health department, if it's better than it was, then that's a public health win. And then we have our continued unique challenges. Our drug deaths, we are scoring very well compared to other states. And that's a lot of work, y'all. That's a lot of work from us, Department of Mental Health, Public Safety, community mental health centers, community partners, and a lot of it naloxone saturation and harm reduction. Access to care is really a sticking point, but we are saving many more people from dying from substance abuse issues. I'm very proud of that. And our maternal mortality rate is slowly improving. It's nowhere near where we want it to be, but we're not 50th on that anymore, folks. When you look just at maternal mortality, we were scored 44th here. So our MMRC report will be released before Friday of this week. That's vetted deaths, studied and reviewed, and that will be through 2021. This data is through 2023. And our forecasting for 2022 and 2023 is looking better. So y'all know how much work's been put into that space, and we're not taking our foot off the gas pedal for that. And one area that does worry me is scoring so poorly with diabetes. High blood pressure, we're 48th. Those two factors, obesity, we're 50th, but y'all, we're 50th with a lot of competition. There are 5 other states that we're all right there together, whereas 5 years ago, we were the uncontested champion of obesity. Now our obesity rates have improved and other states have gotten worse. And so with just fractions of a percentage, we can move up significantly with obesity, and we have to keep working because obesity drives diabetes and diabetes and hypertension drive strokes and heart attacks. So they all factor together, and it's important that our strategic investment impact all of those together. So here is our maternal mortality rates in Mississippi going back to 1913, and the top graph just shows you year by year our maternal mortality rates per 100,000 going forward through 2022. The middle graph shows the mortality rate among Caucasian women, the lower graph among our minority communities, and that would be African American and Hispanics, Native Americans together. And what I do want to point out, we do need to celebrate our wins when we have them. And so we are beat to pieces on this at the national level. My colleagues are always joking, Dan, we're so happy for you. We're so glad to have you. And I say, yeah, just keep on, because I've got my eyes on Oklahoma already. This is showing we have already made huge wins. We're not where we need to be, but we are, the programs that we're all employing are working. There are people alive today who would not be alive had we not had these programs in place. And then I have to remind everybody, these are small numbers. So 1 year can jump either way. You can have a great year 1 year, the next year, the deaths double. But we are looking at the results of the Maternal Mortality Review Committee's work, where they take each death and they investigate it. They study the record, they interview the families, they look at what happened, they determine whether this was pregnancy associated, meaning our lady died and she just happened to be pregnant, or is it pregnancy related, which means her pregnancy caused her death or had a large contributing factor to her death. And then we look at, was it preventable? And if so, what needed to have happened to prevent this death? A lot of work. These are volunteers. And we had the same work with our fetal deaths, with our infant deaths, and our child deaths. And y'all can just imagine how difficult it is doing this work. You're reviewing real cases, real people who have died, and we're over 80% of our maternal deaths are preventable. So that's the hard part when you identify, here's what happened. And here's what should not have happened. And how do we try to keep this from happening for someone else? It becomes very difficult. But, I would show you that we have, let me get mine so I can't see that far over. This going out to 2022, you see 2019, we had a significant bump, and then it dropped in 2020. And then 2020, 2021 were our pandemic years, and COVID was lethal for pregnant women before vaccination was available. And this year's report is for 2020, 2021, and it's really two reports in one. We segregate the COVID deaths, look at them separately, and then we have our non-COVID deaths. And when you look at our non-COVID deaths, it shows our baseline mortality rate went down a little bit more. When you look at COVID combined, you see that jump. You pull COVID out and you see the baseline trend still going down. And what I have to remind folks, small numbers, the needle will jump, but also the smaller that number, the harder the work gets. It's harder to change those smaller numbers. It was pretty easy to get better than 1913. It's getting harder to get better from where we are, which means we're having to do bigger projects such as the obstetrical system of care that is extremely important. And I'll be talking to you about that in a little bit. But the other thing that's hard to do is get the number smaller, but then push it closer to the US average. And then I had to remind people, we're not the only ones working to make things better. My good friend Kathleen Toomey in Georgia is working hard to make Georgia numbers better. My buddy Scott Harris working hard in Alabama to make it better. So I'm having to try to catch up and then keep up. And the only way to do that is to do more than everybody else. And that's what we're doing. And for infant death, again, our numbers are too high, and we do rank 50th, but I do want to show you our trends. And this is a lot of work across the spectrum. I give a tremendous amount of credit to our pediatricians and our family medicine physicians who have worked so hard educating against co-sleeping. Not just don't bring your baby to bed with you. Working so hard to help us communicate back to sleep, putting our babies down on their back. It makes a tremendous difference. And so the top bar graphs are showing you our rates for all infant deaths. And if we just go back to 2021, we had a jump. We had trended down to 8.3 per 100,000 live births. 2021, we had a jump, but 2022, we're down, we're moving down again. 2023 forecasting is looking better again. 2024 is looking better again. And what I really want everybody to focus on is stop focusing on the year to year, because it doesn't tell us a whole lot. What tells us is that 5-year average. Or when you look at a decade worth of trends. And if you look at our infant mortality rates decade over decade, it is still trending down, which I am very, very grateful for. But it's trending down in other states, which is leaving us 50. So I don't want to communicate the message that either what we're doing is not working or we're not doing anything. Between all of us, and that involves CPS as well. CPS is working hard to help us here. Between us and CPS, the medical community, the hospital community, there's a lot of very solid work going on to reduce these deaths, and we will continue to do so. I do expect, hopefully, before I'm too old to do this job, that we'll see the needle move with babies as it has with moms. But we will continue fighting our way through. I love this picture. After I saw the all-cause mortality report and was despondent looking at that, Next thing I asked my vital records crew was show me the babies. And this is more like it. And this is just a nice graphic form, how our infant mortality rates are easing down and that they're getting closer and closer to the US average. Again, it's going to get harder to squeeze that little space, but we have to do it. And we will continue to work hard in this space because our babies are worth it. And we need every baby we can get, y'all. Here's our birth rates. Steadily going down. So our population numbers don't stand a chance. Between our birth rates declining, our mortality rates escalating, and our life expectancy dropping, that is squeezing our population. So we do have a brain drain issue, but y'all, we have a lot of other drain going on that relates to health. And one thing I've been saying is, it's not just brains moving to Nashville, it's brains going in the ground that are dying prematurely.
Dr. Edney,
Yes, sir.
What's the one that's going up?
The other non-Hispanic and Hispanic. So
of all the various ones, Hispanic is steadily climbing.
That's correct.
Exponentially, actually.
Yes, sir. And so the predominant white population and the African American population are both declining significantly. And then the total live births to the left if you look at 2023 and 24, it's a fairly drastic drop. I would remind you that the Edney family is doing their part. My 5 grandbabies. All right, I don't like this. I hate to have to share this with you. I've been preaching that 74 years and 8 months, life expectancy being too low, the lowest in the country, but always gotten worse. The impact of the pandemic and the opioid crisis has got us down as low as 70 years in 1 month. It has recovered up to about 71.8. Hopefully it's going to keep recovering with opioid deaths down and the pandemic out of the way. But I would like to point out we continue to struggle in the Delta. And the life expectancy in the Delta is down to like 68. And that is extremely worrisome. And we have to keep paying particular attention to health outcomes in the Delta. Those are real people, real lives. I live in the Delta, grew up in the Delta. This is important to me. But it is dragging the entire outcome readings for the state downward. Across the board, the Delta core counties have about a 15% worse outcome rate, pretty much across the board than the rest of the state. And you have to look at rates when you're looking at the Delta because the population has dropped. I think we're down to just a little over 300,000. 2010, it was like 550,000, and we're down to 300, 330 in the Delta. But the rates tell us the real picture. And the Delta has exceedingly high maternal and infant mortality rates, still leads the nation, and lower extremity amputations, has the highest rate of diabetes and its complications, heart disease, cancer, you name it. But the life expectancy in Hawaii is 80. That hurts my feelings. I'm 63 years old, and this stuff is really starting to come home. We as Mississippians deserve to live longer like the rest of the country and to live healthier like the rest of the country. And this is segregating out heart disease for women and Black non-Hispanic top left, white non-Hispanic to the right, and other Hispanics at the bottom. But I want to point out a couple of things. There's not as much health disparity here between Black and white women as you may think. There's enough, but heart disease is killing all women. So there's no population that needs to feel safe and secure. But we are showing across the board that heart disease now, post-pandemic, is starting, those deaths are starting to come back down. We definitely lost ground during the pandemic years because the hospitals were full, but now we're starting to see some improvement. We'll continue working that space. Here's cancer deaths, and you see a significant jump in African-American women, all causes of cancer, and versus white and the Hispanic is a little bit better than African-American, but not much. And from year to year, this is an example of what I'm sharing with you. From year to year, things can jump. So just because, 2023 looks so much better than 2022, I can't really pull much out of that one data point. And let's talk about breast cancer, because this is important for women's health. We are not doing well. We are leading the country in late stage diagnosis. We're ranked 3rd in that category, which is a bad thing. So we are diagnosing breast cancer too late, and we lead the country in mortality from breast cancer. So our women are dying from breast cancer at higher rates than the rest of the country. And that all goes towards screening. And the message I want to amplify, at least with this cancer, every woman in Mississippi can have full access to breast cancer screening and cervical cancer screening through the BCCP program. Uninsured women who are of the right age will receive their mammograms, pap smears for free. If they're abnormal, the program pays to work up that abnormality versus, getting the free mammogram in October and it's abnormal, then what do you do? Well, with us year round, we identify it, we work it up. And if we do identify cancer, then they get expedited Medicaid determination. So this program is extremely important, and we are not getting enough mammograms done. We've got to increase our mammogram rates and get them done earlier.
Dr. Edney,
Ma'am.
will you tell us the name of that program?
And where's Dr. Witt? The BCCP program, one of my favorite, breast and cervical cancer. Is it prevention or program? Program. So breast and cervical cancer program. And so it's a combination of federal and state funding. So the legislature supports this. And it allows us to provide access for breast and cervical cancer screening to all women in Mississippi who we take care of the uninsured and the underinsured women. And
so they can contact their local health department.
They can. Also, the MSDH app, which I hope you'll all download. The app, the BCC program information is on the app. It's on the website, but they definitely can call their health department. But we have a central BCCP office that the number is on the app and on the website, and our folks will be very, very happy to help. Madam Chair, before I pose some recommendations for you from our perspective, what questions would you have thus far, or areas of concern that you have, such as syphilis impacting women and infants? Working very hard in that space, very grateful to that extra funding that we had for discretionary public health programs. And I will tell you, I was reflecting on this weekend, that extra 2.9 million that we received for us to invest in public health programs based on what we were seeing. That money has gone into maternal infant health issues, mainly with the obstetrical system of care and with Healthy Moms, Healthy Babies, maternal baby high risk program. And it's gone into our syphilis work and has made a big difference. I can't release the numbers yet, but our forecasting looks like our congenital syphilis for this year is going to be cut in half And we have worked hard, and a lot of partners have been helping us. And let's see, we have been investing in improving access to core public health around the state with those resources. Very proud of our WIC program, Women, Infant, and Children's Nutrition Program, which also supports breastfeeding as well as nutrition for the moms, the babies, and the children. One thing you'll see on the Women, Infant, and Children scorecard, our WIC program scored about 32nd. So very proud of that. We have a strong push to get our WIC numbers up, but I'm very proud of Dr. Jamisha Ballard and her team for providing access for nutrition support, especially breastfeeding. Early intervention, I know y'all spent a good bit of time talking about that. I am proud to Dr. Witt team shared with me that we're up not quite 1,000 little ones compared to when I had to visit with y'all before. So we have not been waiting on the state recommendations. We have been implementing as we've been moving forward. Dr. Witt's team has worked very hard, and we're seeing improvement. We do have a couple of things that we're going to need to bring to help early intervention outside of funding, specifically looking at access for children for 0 to 3 with autism. We're really struggling there, and I think y'all can give us some relief so those little ones can get into the program more quickly. Family planning, huge issue in this space. Although we aren't a Title X provider, which really doesn't hurt my feelings, we have worked really hard the last 2+ years to manage family planning more with a provider model. And we're making sure that all women have access to basic contraceptives, but we're being aggressive with eligibility determination at the health department for Medicaid, for family planning waiver, and for Marketplace, and getting our folks enrolled so that we can provide them the level of care that they need and deserve. And we're being very aggressive with long-acting contraceptives if we have a payer source. So, and then we're partnering with the Title X clinics that if we have someone without resources who wants a LARC, we will get them to that Title X clinic and get that long-acting contraceptive placed.
Dr. Edney, did we clear up, I think we thought we did, we cleared up some of the issues that were taking place on the LARCs with the reimbursement issues on that. We cleared some of that up so that people can get quicker access to that now. Did we not?
I believe so. I believe the fix it's certainly working for us at the health department.
Okay.
And, we have to be really careful if we have a couple of those that aren't reimbursed, and that kills our budget. Right. But they're so effective, and it really spreads those pregnancies out and gets that inter-pregnancy spacing done. That, we have way too many pregnancies that are happening less than 18 months, and that automatically kicks to high risk.
Let us know if we did not, we thought we worked through a lot of this particular issues in regards to reimbursement on those LARCs. So please let us know if if the reimbursement issues are still problematic. So
we surely will. And Dr. Brooks, would you take note? And we'll talk to Dr. Pearson with the public health pharmacy when we get back. Right now, everything's working well for us.
In regards to early intervention too, I'll go back to that for just a second too. The report, as you know, really, we want to look at increasing those numbers. We also, Chairman Blackwell, you and I had conversations with Medicaid too, and trying to make sure that those children that are in Medicaid programs also are counted in our early intervention numbers. But would y'all also look to make sure that the committee made some recommendations on looking at how that we raise our percentage of children that are at least at the national average? Would y'all give us back some hard dollars as to what that looks like from y'all's perspective, and kind of looking at the recommendations at at the bare minimum to get us to national average. I think we would love to see what that would look like for us to do that.
Sure.
In regards to that. Dr. Edney, I want to follow up though on a general thing. I asked Director Bradshaw that this morning. It's a conversation that you and I have had. And you look at these healthcare metrics and they're in different categories of things that we need to look at, whether it be cardiovascular, hypertension, or whatever. It involves so much more than just the Department of Health
Absolutely.
working on these particular things. We've seen it throughout the testimonies that have been looked at, whether it involves mental health, whatever it involves. That if you even look at accidents, the Department of Public Safety is involved in that. So there's so many things, and I know Senator Bryan, I'm going to give you. You have mentioned this multiple times again. Seems to me that it would be very beneficial, as we've talked about, that we have a state plan, not just the plan from the health department, but that when we look at these issues, there's a state plan that y'all have looked at that is then carried through, whether it be our MCO providers, whether it be our different state agencies. And I know other states have that. And I know we've talked about this and you've spoken to other states. I know the senator here is, our chairman has mentioned this. Can you speak to that just a little bit? Because it seems to me that it would be to the benefit of the state to have y'all all with the collaboration, that everybody knew their role, their pieces apart, and the metrics that they needed to hit as a state.
Absolutely. I couldn't agree more. Of August 2022, when I assumed this role, was the month that Greenwood LaFleur Hospital had a sewage leak, and we had to evacuate the hospital. And I've shared with y'all this story. Being a Delta boy, that hospital typically had 150 people in it. I thought this is going to be a mess, and there were like 5. And that got my attention as an internist. A hospital can't make it on 5 people. An acute care hospital can't make it on 5 people. And that's when we, started looking and saw the fragility throughout the Delta, the instability in other rural areas. And also we're able to recognize that our stronger hospitals like Gulfport Memorial, Singing River, that they had taken a beating in the pandemic and were fighting to overcome the challenges they had. But there was nobody, no entity who had authority to look at things comprehensively and come up with thoughtful strategy. And we were just having to do it manually and trying to share with y'all what we were finding so that you can make the decisions you needed to make. But last year, last year EMS hits the fan, and it's always one thing after another. So I initially was challenged a good bit when y'all assigned to us the new responsibility to study healthcare comprehensively, and no authority to do anything, but the authority to really study it, which I was, meaning that Peer had to help us, that the other state agencies had to help us, they had to cooperate with the study. And then you gave us specific challenges like healthcare for the incarcerated. Thank you very much. And but the more I have worked on this, I mean, it makes perfect sense. It's our first step. And it's too early to say what we're going to be bringing to you, but I suspect that, we do need to pivot back to the old days of the Mississippi Health Commission that predated CON. And we made the decision to move from the Healthcare Commission that actually did do strategic thinking and had some authority to CON, expecting CON to control things. And as I've shared with y'all, CON does not improve quality. It does not improve access. It does prevent cherry picking, which is really important in small rural areas. It protects the entities that need to be protected, but it does stifle innovation. No two ways about it. We've clearly shown that and reported that back to y'all with the state health plan vision. So what we're doing at the health department that fit perfectly with the new assignment, and it really just pushed me, we have to do this. A year ago, I divorced the state health plan from CON. And up to that point, the state health plan served the needs of CON and really didn't do much else. And it was about the only thing it was used for, was if someone was going to apply for CON, they had to go to the state health plan and look at the data. What we're doing now is the state health plan will be the state health plan, as we as the Department of Health see it, in terms of here is our capacity in various areas. Here are the capabilities of our hospitals in various areas. Here where our clinics are, our FQHCs. I can tell you, we do not have enough OBs in the Delta. There's just no two ways about this. If you hand count them, the core Delta counties, there might be 7 serving 300,000 people. So these are things that you need to know. And at this point, we're actually having to manually do it. Board of Medical Licensure can't tell you that. Nursing board can't tell you who's delivering babies. Office of Physician Workforce that's now with us is able to do that and plug that into the state health plan information. So as the state health plan is reconstructed under the new vision, it will be a repository that's frequently updated with data as fresh as we can keep it, that y'all as legislators can reference as you're having to make tough decisions. And that's going to be a little bit of a chore, but it's worthy of us doing it.
Okay. All right. I'm all for that. But what I want to make sure too is that other providers, other departments and other agencies that do that y'all are all working in the same direction.
Absolutely.
How is it that, and share with me how it is in other states that we make sure that like our managed care organizations, that they are working with that same data and putting priorities in the same areas that you do, the Department of Mental Health, CPS. How is it that in other states maybe that they all come together to know that these are the priorities and these are the areas that we need to move the needle? And how is there accountability for that?
The accountability is a big piece, Senator. It really is. And the answer I would give is that many of us are trying. I mean, there's a strong cooperative effort between health and human service agencies, all of us. And the only way this will work is we can't have a mental health plan. We can't have a child protective service plan. Obviously, those agencies need that, but the state health plan needs to be global health. It needs to be comprehensive health. It needs to be health and, at all stages, all phases. We have to stop divorcing mental health from physical health, and make sure that the state health plan cares about mental health. And we are able to show you how many acute psychiatric beds there are and where they are and how many are in abeyance. Where are the substance abuse beds and which ones are private and which ones are CMHC based? And where are the psychiatric residential treatment facilities? How many beds are they? I mean, these are things that it takes a little effort to get today that needs to be just seamless for anybody who's working in any space in health who needs information, not just data, but information, and that we are able to provide that. That still doesn't get to the authority to make things happen. Believe me, I'm not asking for authority, but somebody in the state has to take this, we're going to spend this money, we're going to work really hard to develop this, somebody got to look at it. And then somebody has to do something with it. And obviously, CON in whatever form y'all determine will have to go to the state health plan. Instead of the state health plan feeding CON, it's reversed. But still, I mean, no one's ever had taken on the challenge of, well, we don't need 110 hospitals. How many do we need? And what do they need to look at? Where do they need to be? You know, that there are a lot. Yes, sir.
Dr. Edney, sorry, you brought it up, so I want to have a discussion.
Please.
I don't disagree with you. But man, when we talk about that, you thought we were shooting the person's kid if we're not going to have a hospital in wherever. And as expert as you are, but I personally have weighed in on that. And people attack me because I've said we don't need a hospital in every single county because the population doesn't support it.
That's right.
I mean, at what point, and then, sorry, you got me. You intrigued me, the CON.
Mm-hmm.
I mean, it's like we've turned over our public health to the special interests in a lot of ways. And I'm intrigued, so I have a question here.
Okay.
You mentioned going back to the way it used to be before. What is your vision for that? Like, when you said that, what do you mean?
Well, I think it would be smarter than to have a state agency running numbers and saying, yes, you can, or no, you can't, to have a panel or a commission of experts who are working with that agency, us, together to determine what is legitimate community need. And that just makes more sense to me. I do things the way we do them because y'all tell me to do it that way. I do think there are better ways to do it. And it really hit home during the rural hospital crisis. Many folks don't know how close to the edge we were. And, you know, but I kept being asked, well, what are you going to do about it? I'm doing it. I'm telling you, we got a problem. That's all the authority that I have. And during those days, y'all were having to make some really tough decisions through legislation without,
but what we heard was if our hospital goes under, oh my gosh, it's the end of the world. That's what we were being told. And so we spend hundreds of millions of dollars to prop up a system that is going to continue to do the same thing. I mean, you see the population numbers. They're continuing to go down, and they're going down in certain places.
Right.
I don't understand why we, meaning legislators, continue to get, when people like yourself say, we've got to decide and make decisions, and then when we try to make decisions, we're told by the people that don't close my hospital. Even though we have 20 people in the community, I want a full service emergency room.
Mm-hmm.
The economics don't work.
So
and
that's
we've got to do something. But everybody wants, I'm sorry, I've been on public health since I've been here.
Yes, sir.
And everybody in public health wants, it seems to me, and hearing you today, wants to protect their region or whatever instead of looking at the public health overall of the state. That's what it seems to me like.
And that's natural.
It is. It's natural
and understandable. But what we're able to do is to show the evidence of why that is what you're saying is true. And so as we were looking at the Delta hospital crisis, as y'all were moving into the 2023 session, I had already had conversations throughout the Delta. You know what most of them want to do? Downgrade the hospital because they can't, because to upgrade means it would cost much more money. They would have to staff it. They would have to do that. Right.
And that's what I call right-sizing. It's almost like we need to
I would agree.
right-size our healthcare system in the state for where things are now, not what they were 100 years ago or what we think they should be.
No, I totally agree. And so we have, I was in a small community last week with a small community hospital. That little hospital is important to its community, but there is no pathway for them forward.
Yeah, and nobody's saying they're not important. Look, I've been through it in my area. They're not important.
Right.
The issue is sustainability. And
That's the issue.
so the issue is sustainability and quality. And we have to think outside the box, which to me, it sounds like that's what you're doing. And I appreciate that.
Thank you. That's what we're trying. And so I appreciated them asking me to come to talk to them about their options. And I was happy to. And it was a small hospital I had not visited yet. Wonderful little hospital. Their census averages 1.2 as an acute care hospital. The numbers won't work. There's no way to make those numbers work. They don't have a pathway to rural emergency hospital because they don't have an ER. So we were looking at alternatives, and some of which CON was getting in the way for their alternatives. They have a psychiatric program that's strong and robust. They wanted to expand it. The community need is there, makes sense to me. We got CON problems, that y'all are looking at. The right sizing is the correct way to put it. And some of it is reimagining ourselves. And we're doing that at the health departments, that we don't need 88 little county units all over this state trying to do what they've always done, and basically very few of them accomplishing it.
But that's what.
So we have
88 counties, 82 counties say I want to do it 82 different ways.
Right.
And
Well, at least
that
I have
does-
authority over the health departments to right size them.
I understand.
So that we're right sizing the county health departments in a way that won't be a burden to y'all or to the counties, and improve the effectiveness of community-based public health. Same thing is true for the hospitals, and many of them get it. I think 2 years ago or 3 years ago, we had no rural emergency hospitals. And for those of you who don't know, that's a hospital that's given up their inpatient service, but they keep their ER and their outpatients, and they can do overnight observation. So they're still open. They still have payroll. They're still supporting the community, but they just don't have inpatients anymore. Those days are gone. So they're right sizing themselves, and we're trying to help them. What will be better is when we get to the point where we can clearly say REHs make great sense in these zones. Not say that folks have to be in RH, but just be able to tell y'all, this makes sense here. Critical access hospitals make sense here. We must have acute care hospitals, X, Y, Z, A, B, C. I mean, we do have a critical mass of acute care hospitals we must have to serve the state.
Is that something y'all are looking at?
Yes, sir.
That you will propose to us at some point?
Well, what we will do, the state health plan will inform you of that.
Okay.
How's that?
Which I think goes to what the chair lady was saying about a state health plan.
Yes, a legitimate,
legitimate,
accurate state health plan. And today I just have to embarrassingly tell you, we don't have one, but again, it's better than it was, and it will keep getting better. And it does impact, the issue of CON impacts women, infants, and children, because the Board of Health recommended lifting CON from perinatal services. So hospitals, can build whatever program to serve women and newborns and not have to worry about having a CON. We're looking at innovative ways such as rural healthcare exemptions, that if you're in an area of the state, critical needs, we need access, you're wanting to invest in your facility, you don't have to get a CON to do that. So a lot of common sense things. So I've been really interested in the conversation that is occurring at the Capitol. Board of Health is working thoughtfully to give recommendations for y'all's consideration, not introducing legislation, but just, here's our perspective. and then, and hopefully be that trusted source of information for you that when you have questions, you know that we'll give you a straight answer.
Chairman Braun.
Well, a while back, I just had a couple of things I was going to point out, and then the more these two have gone on and on and on, the more exasperated I get with them. We've got this doctor here and this little boy whose daddy was a doctor, and they're all excited with each other and sort of see themselves as the Robert Moses of Mississippi and on and on. And I'm sort of a first do no harm guy. I don't know if y'all have ever heard that. First do no harm.
Yeah, it's important.
But to back up, to answer the question that you asked, some states have essentially a cabinet officer who's the Secretary of Health for the state, and it's a long rambling story, but I was, when there was a different governor of Michigan, I was the guy who was the cabinet person in Michigan for health. So, well, I'm the cabinet guy when the Republicans are in charge, and then I have this counterpart over here who does this when there's a Democratic governor. But basically, that's the place that looks comprehensively at healthcare in Michigan. And so that's not the system we have here. But I was going to point out, there is this provision that we put in last year's powers and duties section of the State Board of Health that explicitly tells them to come up with a plan, tells them to think comprehensively. And it says they can't make any other agency do anything. It also says every other agency has to cooperate with them and give them information and on and on. And so the thing that I think is the first thing to do, which Dr. Edney's alluded to, is let's just get some data that's real data. Let's find out what's where, who the doctors are, who the facilities are. And it's sort of shocking that we don't know that. But now we know where to go to get that information. And I will say, as far as what this entity over at the Department of Health is supposed to do, Daddy told me that during World War II, there was a guy who had a way to solve this problem with those German submarines, which was simply to raise the temperature of the ocean several degrees. It'd be so hot they couldn't stay there. And the response was, well, yeah, but how are we really supposed to go raise it? He said, well, I've given you the idea. That's just a technical problem. So, I mean, that's sort of what we've done is, we've given you the instruction to raise the temperature of the ocean, and you just figure out the details and get back to us. But I mean, honest to goodness, I keep telling people all any of us ever did was just win an election, and here we are. And I do think that given time and given, I don't mean to say not a sense of urgency, because there is a sense of urgency, but not in the sense of a deadline, that getting a group of people together to sit and talk and listen and gather data is going to go a long way to telling us where we need to go. And now back to this proposal y'all have to depopulate rural Mississippi. It's almost here you want to go tell everybody to get out of these rural areas and move to Oxford or something. I think that the concern that some of us in rural areas have, and this whole state's rural when you look at it on a national level. I mean, you've got the Gulf Coast, you've got the Jackson metropolitan area, and you've got suburban Memphis, but the rest of it's just rural. And so the same thing is happening to everybody on a national level. And what I think gets the adrenaline pumping is external things happening and external decisions without feeling we have any input. And a sense that there's an urgency in explaining to everybody how you can't have anything instead of an urgency or a desire to say, what is it that we can put in rural areas? What can we put in smaller communities to allow those smaller communities to thrive? And there are a lot of medical facilities and things that can be out in the sticks just as easily as they can be all stacked up on top of each other in South Madison County. And so I think that we're headed in the right direction, but I also think that there's something to be said for getting the data and scratching our heads and thinking. And I will, I'll make 2 points and I'll quit. One is this example that I keep giving that everybody's sick of hearing, but it's the only way I know to say what I'm talking about. And Bryce has been talking for years about the concept, because we've of a nursing home to parole people, because we've got a bunch of people in Parchman who are eligible for parole, but cannot be paroled because there's no place for them to go. They don't have a place to go to. They're old and sick, and for some reason, their cousins aren't real interested in having somebody they've never met who's been in Parchman for 40 years come stay with them, for 5 or 6 years. It's a sad situation, but it's there. So the idea that I heard about from Bryce is you would have a nursing home, in fact, if not de jure, built to take care of parolees. And then when the parolees go to the nursing home, they would then become eligible for Medicaid because they would not be in a correctional institution or whatever the buzzword is. And that would save the state money. Well, and provide a better deal for them, and Parchman could stop worrying about those folks. Well, thinking more about this, and at the early stages, this won't cost the state any money because it's all going to be run privately. Well, it costs the state money in the sense that we'll be paying for the Medicaid. It'll save money on the other hand over here at Parchman. But that's going to be a money-making operation. Why not, hypothetically, looking at the big picture, give a certificate of need to Greenwood LaFleur Hospital to operate such a facility? That facility could operate in Greenwood. It would provide employment for people who have some medical experience, whether at the hospital or wherever. And it would also provide some revenue for the hospital, and it would provide some individuals who would need to be admitted to the hospital periodically for treatment. And there's no way to get that done because there wasn't everybody doing everything. But that's the example of things we can do with the money we're spending on healthcare to make things better. Dr. Edney mentioned in passing the contract for Parchman. I'm absolutely convinced that the contract we have for healthcare for Parchman is costing us too much money. It's providing terrible care for the people in the Department of Correction, and there's a pile of money going outside the state of Mississippi to somebody else. There is a way to capture that and provide healthcare, some group of people somehow in Mississippi, and then that, I just think those are examples of things that could come about. The other thing that let me just mention in passing,
Well,
we have
on that, Mr. Esteemed Public Health Chairman, which I do recognize, I agree. And that's the
I'm not only esteemed, I'm 100% right.
You
remember
are.
that from this morning.
You've been esteemed and right today. My comments were not to depopulate rural America or Mississippi by any means. It's the right sizing that we talked about, and what the esteemed chairman of public health is saying is the point I'm trying to make, which is to be thinking outside the box, because we've got to preserve these places. And how do we do that with what we are facing? If anything, my comments are a reflection of what goes on in these halls whenever this discussion comes up and the lobbying that goes on. And I don't even know, I think it was last year, there was a plan that was presented. I don't know all the politics, a plan presented in the Delta, and that got shot down. And
Well, it got shot down largely by the legislative delegation from the Delta.
yeah, I did, didn't it? Thank you I forgot about that. Because, and so to the point about we've given the Department of Health the authority to look at that, which is what the chairman has done, I think is great. And so when that comes to us with the expert opinions or looking at that, we need to be willing to look at that and implement that, and or at least seriously consider it. And if I understand where Dr. Edney was going, which is we can't keep doing the same thing over and over again and expect different results. But yet, when it comes up in this building, we always seem to want to do the same thing, expecting different results. And I know that, so that's really what I was getting at. But I think this is a worthy discussion because we've got to be looking long-term to fix this.
Reclaiming my time,
Yes.
as they say in DC.
Yes.
First of all, Haley Barber's the one that started using this word right-sizing. We ain't recovered from it yet. It's a trigger for some of us. So, I mean, it's
Sorry.
just.
That was before my time.
Well, so many things were. And the previous speaker has this chart that shows the Delta is not a maternal care desert, which.
Well, thank God.
But-
I can stop working in the
But
Delta
what
then.
I was going to say originally, before we got off of this, is that, and Bryce mentioned he wanted to look at something long-term, and this is long-term. Dr. Edney has mentioned the ability to deliver public health information to children in the public schools, which is something that we did when I grew up. You know, we had the 3 basic food groups, although we don't have that anymore, but you got instruction in health just as part of being in school. And we've got to figure out how to do more of that. I don't know how, but Dr. Edney, I think, is speaking to the state superintendent of education. And I think they have an ongoing, and I don't know what to do. You know, there once upon a time was this preacher who, while the other preachers were buying 15-minute programs on the radio to share with everybody all the Lord had put on their heart, decided instead to buy 1-minute spots and had more success with the 1-minute spots than the 15-minute sermons. And of course, Dr. Ed Hill, for some of us that grew up in that neck of the woods, had the 60-second house call. I don't know if literally some 60-second or 2-minute thing every morning about the healthcare tip for the day, I don't know if that's more effective. I don't know if it needs to be part of the curriculum. I don't know. But I'm absolutely convinced that if we're going to fight obesity and we're going to fight diabetes and we're going to fight all of these things, you've got to get information to the children. You've got to start changing real world behaviors. This happens. There are people who get up backpacks for children to take home with them on the weekend because it's a small town. They know, the teachers know there are these kids that really don't have enough food. So they get it back. But what goes into the backpacks is a bunch of junk food because it will last forever by definition. And it's convenient to get. And so, you know, I tried to argue in favor of apples at one point. I don't know. But I was going to mention and ask Dr. Edney to mention it because I think if we're looking, as you point out, there are a lot of things going on with healthcare and we're treating the downstream results. That sure seems to me something we ought to be doing. Has that happened yet? Have you got the 60-second spot cut?
No, sir, I think we're at 18 seconds right now. We're working towards it. I have to keep referring y'all back to this graph. Because, Ms. Chairman, neglect is harm. So many times, first do no harm, primum non nocere means not to intervene, to make it worse. But then there are times a failure to intervene makes it worse. And we must correct this. This is unacceptable to Mississippians. I'm showing this when I speak upon invitation, and everybody is shocked, as shocked as I am. This will not fix itself. This is not going to organically go away. We're working hard in many areas throughout this state with many partners to improve this, and I'm anxious to see that 2023 number. But there are things that have to happen. One of the things is to study healthcare and look at thoughtful provision of healthcare for the 21st century to make sure there are institutions and communities the way it makes sense. But the county systems don't work in many respects. It doesn't work for EMS anymore. It doesn't work for public health anymore. But these communities all need to be served. They need to be served well. They need to be served better than they're being served today. The hospital I was visiting with last week, I asked them specifically, I said, what if you could have a contract with the Department of Corrections for this to be your infirmary instead of what we have? Would you be willing to do it? They say, we would fill every bed if you would let us. And they're not the only hospital. So I think your recommendation is worthy of study, which, we'll do. I also want to remind y'all, there are a lot of women who are incarcerated, and they have infants and children at home. We have pregnant women incarcerated. When bad things happen to them, they go to our numbers. We don't have it segregated out. It goes to our maternal death numbers, our infant death numbers. And it's very important that we, and I'm pointing fingers at me, is we must do a better job overseeing the healthcare of the incarcerated, not providing the healthcare. But did y'all know that we run the TB program at Parchman? Aren't y'all glad? We don't want TB going down into the community upon discharge, upon release. But we have syphilis and HIV and Hep C. We have young women developing breast cancer and catching it. There's a lot of opportunity. That's 20,000 people. So I take the challenge that y'all gave us very seriously, and we're going to do it to the best of our ability.
Dr. Edney, I'm going to move you to another area really quickly. With this last year, we proposed a bill and we got it through the Senate chamber that was on community health workers. The Department of Medicaid presented earlier that they were going to use community health workers in maternal health care. We don't have the breadth, when you look at other state, of other healthcare professionals that you find in other states, whether it be doulas, whether it be midwifery, which we're going to have testimony about in all those other areas. You had to try to expand and get the certification for community health workers. Can you talk to us just a little bit about that expansion of healthcare workers that many who are not as costly as some of the individuals that are seeing them now? It also gives those healthcare workers who have other expertise the ability to do what they're trained to do and not perform some of those other tasks. Can you talk to us just a little bit about that?
Yes, ma'am. Recommendation number 5.
Okay.
So community health workers are vitally important in the population health space. And the science is moving us that way. The purpose of CHWs is to have a lower cost paraprofessional working in the public health space to help us mitigate social determinants of health to improve outcomes. And this is not a new concept. And we're actually trying to catch up. And we're using especially Kentucky as a model, and we're getting the right numbers to project how much it would cost the Medicaid budget. But CHWs wind up paying for themselves. I know y'all hear that all the time, but this is legit. They do wind up paying for themselves. We desperately need them at the health department. Now, we have 40 of them, but I need a CHW at every level 3 clinic around the state to work with our high-risk individuals who we're worried about. And we have to get away from the old days of identifying a high blood sugar, giving the orders, giving a referral, see you back in 3 weeks. They come back in 3 weeks, nothing's changed because of 15 different reasons. CHWs go into the community with these high-risk folks, especially with public health issues, and they navigate for them, they educate more, they intervene with social determinants of health, they make sure people get to their mammograms like they're ordered, they make sure they're going to their diabetes self-education classes, they make sure all these things that need to happen, and they are very effective. But these are individuals with lived life experiences with social determinants of health. They have to be from the community and live in the community. And then we train them, and it's about 140 hours of training, and we certify them. And then they really augment the public health workforce. I couldn't find the nurses if I had the money or the social workers to do what we need to do. And if I could find them, I couldn't afford them. CHWs are there, I can afford them, and they can help my nurses and my social workers move the needle. So they work under the direction of our public health nurses and our public health social workers out of the county health departments to change all the things I've been presenting to you and to get our early intervention numbers up. Do you know how many referrals to early intervention we have and then we can't find them? Or how many referrals to healthy moms? By definition, they're a high risk pregnancy, and then we can't find them. CHWs find them, and they close the loop for us. So we advocated last year. We're very close, but what we're asking for is to recognize CHWs as part of the public health workforce. We will, with our authority, certify them, and that if they are certified and working for a Medicaid provider, then they should be reimbursed as other states are doing. And it makes an awful lot of common sense. That enough? Okay. So I will quickly run through, and these are my recommendations. I'm not putting this on Board of Health, not putting it, this is my thinking after processing all that I have presented to you and work with this every day. These are the things that make sense to me for your thoughtful consideration. Number one, if we don't close the coverage gap, nothing's going to change. We just have too many Mississippians who cannot access a primary medical home, and we deal with this every day at the health department. We do the best job that we can. The FQHCs do the best job they can, and it's just not enough. A big part of maternal health issues are women who are high risk before they get pregnant, but they're not in care. And so they're getting their insurance because they got pregnant, and now they have access to care, but it's too late. They're already a high risk pregnancy. Get them into a medical home. I know this is easier said than done, but get them in medical homes, get them access to good comprehensive primary medical care, mitigate those risks before they get pregnant, help reduce them from getting pregnant when they are identified as high risk. Make sure they know you get pregnant, you could die, and help them not get pregnant if that's not what they want. But we have to do this. I don't care how you do it, but we have to do this. This is a very big part of our poor scores. We get clobbered on that. To Senator Bryan's point, investing in school-based health education, intervention, and resources. This very comprehensive, but it's cheap. And this is getting primary prevention education into the schools, especially K through 6, like Dr. Ed Hill promoted, continues to promote. But in my thought is to embed a little bit of health education into the school day every day. You know, these one health class doesn't achieve anything, but help teach children what obesity is, how not to get diabetes and hypertension, how to be healthy, why exercise is important. You know, just the basics, teach them that. Intervention, we're talking about mental health intervention, right? In the school systems, absolutely 100% necessary. But we need to be intervening for that 4th grader with uncontrolled asthma that's missing a whole lot of school. We need to intervene for the 3rd grader that's already obese. That little one is doomed if we don't intervene. How do we intervene? School nurses. We have to really reevaluate. You know, we gutted the school nurse program. The health department provides for 56 of them around the state through the tobacco trust fund money. But, you know, if every school district had at least one school nurse, they can make a difference. They really can. They know those kids. They can intervene. They can help educate. And they're so important. And I don't know why. It has cost us an awful lot of money to move away from them. And we need to get back to it. Broad-based community education, rewarding simple behavior modifications that will improve health outcomes. Again, Senator Bryan's point, it's not just educating children in school, it's educating our entire population. Because I have to worry about the little ones that are in 4th grade, what their life is going to look like from health. But also I have to worry about their daddy and try to help him not die at 54 like my daddy did. You don't think that rocked my world as an 8th grader to lose my father to colon cancer? This stuff impacts children, and we have to educate people how to stay healthy. And we have evidence-based programs to do that if we have the funding to do it. A little rewarding goes a long way. Incentives do work, y'all. You know, the Medicare Advantage programs will pay somebody $50 to go get their colonoscopy done. They'll pay them $25 to get their mammogram done. They give them $25 to take their flu shot because it saves them money. And folks will do it for that. Please support us as we work more robustly to reduce childhood deaths from firearms, drownings, co-sleeping, motor vehicle accidents. As you see us moving into that space early next year, please support us and help us do this. This will save the lives of so many children. Talk to you already about CHWs, and support the infrastructure of access to rural healthcare providers, especially in critical shortage areas. We talked about that a good bit already. One thing I'm advocating, you know, the Rural Scholars Program is wonderful, but rural is a pretty big definition. And there are places that rural scholars can go that really, to Mississippi standards, aren't that rural. We've got some critical healthcare shortage areas that we really need to incentivize doctors and nurses and dentists and physical therapists, whomever in the workforce we need to go there. We can do that through tax credits. I mean, redesign the scholarships a bit to incentivize them to go to the critical needs area. But this goes back to the study of healthcare, Mr. Chairman. I would really suggest that y'all consider a commission or a task force. You could actually just contract this out. There are entities that can evaluate where we are with our 1115 Medicaid waivers, and they can tell us where we're missing out. And I can tell you we're missing out on a lot. You know, there are other states, there are other non-expansion states that are working robustly through increased federal funding through 1115 Medicaid waivers. And I want to support my good friend, Director Wendy Bailey with mental health, and support her request for an 1115 waiver for mental health and substance abuse. It will save the state treasury millions of dollars to do that. It's a way that you can fund state hospital. It's a way that you can improve access to care for women who need substance abuse treatment and mental health treatment. Other states have already done it. We don't have to reinvent the wheel, but there's opportunity for experts to show us where we're missing out. Wouldn't cost us very much, and then we could give y'all a better perspective. And then I have to end by saying, won't you please adequately fund public health? I'm very grateful for the extra 2.9 million we got last year. I think we have used it very wisely, and we'll show you a return on that investment. But y'all, I'm pretty certain I'm about to get some big cuts on my federal dollars. I need y'all to be thinking about that with me. 80% of our budget is federal. If we take a 20% haircut from our federal funding, it's going to be challenging. So lots of opportunity to fund public health in a wise way, not just dumping money in a state agency, but working with us to make strategic investments. But the main thing I'll be asking for this year from a financial standpoint is, continue to make those discretionary investments. It was like a block grant that you gave me last year, and continue to do that, expand it a little bit so I can show you what we will do with it. I'm so proud of that new assignment y'all gave me, but there was no money with it. I'm having to build a new office of state health policy and planning that's going to be about 6 FTEs to do the work that y'all want us to do. No funding came with it. So, Madam Chair, I appreciate the opportunity so much. Always glad to be here and visit with y'all, and always happy to answer questions.
Dr. Edney, we thank you and we appreciate everything you're doing to kind of move us forward. So we're going to take a break. We are going to start promptly back at 3 o'clock. So everybody stand up, and we'll start back at 3.
Thank y'all so much.
All right, y'all, we're going to go ahead. We're running a little early, which we never do. So we're very excited about that. But we're going to go ahead and have UMC come up here. Dr. Rachel Morris is going to start us off with an update, I believe, on some of the programs. And also we are going to have Dr. Morris as the Associate Professor in Maternal Fetal Medicine. Then we have Dr. Marty Tucker, who's appeared before this committee, I believe before. He's chair of the Department of OB/GYN. And then we have Janice Skaggs, who's the Assistant Professor and Certified Midwife in the Department of OB/GYN at UMMC. So if y'all will come on up, and we look forward to hearing from y'all. And thank you.
Hello, here it is. Good afternoon to everyone, and Chairwoman Boyd, thank you so much for having me today. Again, I'm Rachel Morris, maternal fetal medicine specialist by training, have been at UMC for 20 years, and really pleased to talk to you about STORK today. Let's see if we can make this work. Okay, so STORK is a program that began in 2021 out of the Mississippi Center for Emergency Services. If you're not familiar with Mississippi MCES, as we call it, it is the house for everything you see here. So air care, children's and neonatal transport. Of course, there's three common core efforts of MCES. That's education, patient care, and research. So out of this phenomenal program that's located on the campus became this concept of STORK, which was really intended to improve maternal and infant outcomes that were notably insufficient over the last several years, and really prior to some of the major changes that have happened in the landscape of Mississippi. So STORK stands for Stabilizing Obstetric and Neonatal Patients, Training and Outcomes, and Resource Sharing and Kind Care for Vulnerable Patients and Families. And to be honest, again, we started our efforts thinking we would train just 10 classes and perhaps 100 people. And STORK grew to be something much greater than any of us anticipated. Our STORK team is here. Again, you can see we're quite small, but a very impactful group here. And all of the STORK, the meaning behind STORK has to do with our maternal mortality rates. And so across the country, you know, we certainly have high mortality related to hemorrhage, cardiomyopathy, hypertension. And if you look at Mississippi's data, again, like the US, unfortunately, there's pretty significant healthcare disparities. Our Black mothers are dying in larger and greater rates than any other race, and certainly something we address with STORK specifically. We look at our report cards, it's not only our high maternal mortality rates, but our infant mortality rates are certainly the highest in the country. And these are some of the things that we address specifically in STORK. STORK covers several topics. And again, we have a handout sheet for you. So we assess the pregnant woman, we treat for preterm labor, and we teach people how to recognize and to intervene and to diagnose preterm birth. But there's several important interventions that anyone can do to decrease the rates of preterm delivery. And if unfortunately a preterm birth is going to occur, some really important steps that you can take to afford a better neonatal outcome. As you see here, some of our props. We have our Annie. This is roughly the size of a 26-week infant. Again, we teach people how to resuscitate an infant of this size. And this one, again, much more 34, 31-week size infant. These simulators that we use are incredibly high fidelity and probably the best that exist. We're really lucky to have such equipment to teach people with. Again, and most alarming to me as a practitioner is that the vast majority of our deaths here in Mississippi and across the US are preventable. These are statistics that should sit well with no one, and this is what drives me every day of my life. So again, what we cover is pretty robust. There's about 2.5 hours of lecture. Again, assessing, treating preterm birth, again, hypertension, preeclampsia in the spectrum, and super important as our patients are presenting to local, rural locations that do not have formal obstetric training and often are misdiagnosed or the true problems are under-recognized, and these patients are going on to have sequelae. My most favorite thing to do is teach someone how to deliver a baby. We're talking about patients in remote areas in the obstetric care deserts where there is non-obstetricians running emergency rooms, and these patients are delivering. And again, teaching someone how to deliver a baby and how to recognize emergency triggers prevents emergency. And then the second half of our training has to do with the resuscitation of the infants and newborns, which also, again, goes hand in hand. This training program is unlike anything else across the country. There are phenomenal programs that assess maternal care and delivery. Again, phenomenal programs that assess newborn care, but there is nothing that combines the two with a specific focus on the emergency first responder. Again, whether you're a nurse, an ER physician, a paramedic, again, air care nurse, again, this really applies to everyone. The education component is what, blows all boundaries and makes this training unlike anything else. We have 4 simultaneous maternal and neonatal simulations that really underscore the education we're getting at. Again, and this is just something offered at no charge. We go anywhere with all of our facilities and bring the training really to the places that need it the most. It is a whole lot more than education. Again, you'll see behind me our stork bags. We're fortunate to be able to provide everything you would need for a delivery and a resuscitation of someone that small. Again, it has our references, again, links to an app where the providers can review the information if they've forgotten something. There's supplies and everything in these bags are replaced at no cost. And again, of course, for our nurses and physicians and EMS, you can even receive CME. So again, like I mentioned, we started with a goal of 10 classes, 100 people. And our first class was a pilot class to the air care paramedics, some of the finest in the country. And this was when I first knew that we had stumbled onto something nothing short of amazing. We've trained almost 1,000 people and almost 60 classes. It's pretty remarkable endeavor. We've trained small, we've trained large, we've trained 75 at a time. It's really pretty profound what we can do. This is a quick little video about what Stork is all about. Ooh, I don't know if it's going to play the volume. This is a training class at MCES. We have hallway training where you have, yep, there you go. Thank you. This is us delivering a baby. Again, this is very real life hands-on simulation. Every scenario that we use is based on an experience that I've had or experience that I've received. Again, you see several familiar faces of us delivering a baby. This is, again, is a training session early on at MCES. This is Emily Wells, our newborn nurse practitioner, and my sidekick and phenomenal training expert. Again, so you can see the isolette with someone performing bag mask ventilation on a newborn. Again, here you can see it. We have monitors and vital signs. Again, this makes this simulation incredibly helpful. Again, they're drying and warming and stimulating. So teaching someone this kind of material in a calm, otherwise, non-intimidating scenario creates muscle memory. So that in the setting of obstetric or neonatal emergency, you know immediately how to respond. And that's the whole goal, is they don't have to deal with obstetric and neonatal emergencies frequently, but when they do, every second matters. Even learning how to breathe for an infant, again, perform an intubation. These are life-saving skills. Again, you have minutes to do this. We talk often about even hemorrhage for the mother. You have 5 minutes before she hemorrhages to death. Again, we don't have the luxury to wait for maternal stabilization or forces to arrive, and these places need to know what to do. I apologize that the volume's not working. We've had a lot of really good feedback about Stork. Stork is something, again, this is the original Stork team. Similar to MCS's goal is research, education, and patient care. There is a research component that we have ongoing with Stork. And what we're looking at is the provider's comfort, using a Likert scale, their level of comfort with respect to the training with before and after, again, whether it's obstetrics or neonatal resuscitation. Again, our preliminary research is incredibly positive. Again, this is just a few areas. You can see we set up in Indianola in a gym because it was the only location. Lots of these places have such limited resources and such limited staff. We've trained respiratory therapists, again, nurses. You have to go where they are because they can't leave their facilities to come and learn about Stork. You have to go to them. But again, this is Victoria in one of our early days. Again, the training has been ubiquitously profound. Again, the pre-hospital providers have been very, very supportive of the training. Again, we couldn't say any more about, and just really pleased to be able to do this. Again, much more than we ever thought we could. Moving forward, again, our goals are to kind of look at our patient outcomes as well. One of the things that is in the supply is a heating element for neonates. And so we'd like to look at some of the centers that have taken Stork and actually do some patient-centered data to show an improvement in neonatal temperature. If you're not familiar with neonatal resuscitation, temperature is a measured outcome that directly correlates with outcome. And so by providing heating elements, teaching them about the importance of heating an early premature infant and how that saves that child's life. Again, if we can show an improvement, I think it'll be even more powerful to show the impact just with one vital sign that Stork is making. I certainly am here for questions. I don't know how much time is left, but please go ahead.
Thank you very much for that presentation. Are there any committee members who have questions? Yes, sir.
I'm sort of still at square one, but my understanding is that, as a matter of fact, there are women giving birth in all over the state in places that are really not set up for that. But in fact, the woman's there, she's in labor and she's at this place, this hospital, whatever, simply because all the other alternatives are worse and the baby's being born. And so the goal of this is to find people who will be present when there is a birth taking place, frequently one that's premature, and train them how to deal with that.
Absolutely. So over 50% of the counties in Mississippi are considered obstetric care deserts. So that means that there's not a trained obstetrician or certified nurse midwife anywhere in the area. So it means that patients who are high risk or low risk have to travel a large distance to receive adequate obstetric or neonatal care. So you're right, women that have term and healthy infants are birthing in places that have no obstetric training or ability to resuscitate a newborn in the setting of emergency. Again, more concerning are the premature infants and mothers in an obstetric emergency that are having an emergency in an area ill-equipped, not only for the normal, but the grossly abnormal. Furthermore, for any of the complications that occur in the prenatal period, so before the baby's born or after. I often talk about the young woman who's 21 years old who presents to the ER with a headache. Doesn't seem that bad, does it? She doesn't tell anyone she delivered 2 weeks ago. Her blood pressure looks fine to the emergency provider. She's sent home and she dies because she has preeclampsia and then has an intracranial hemorrhage and a stroke, and she's unable to be resuscitated. This happens not too infrequently. So teaching the emergency room provider what vital signs are abnormal, what occurs in pregnancy in the immediate 2 to 4 week postpartum period. Again, how to survive a delivery, how to prevent a hemorrhage, how to manage someone. Again, trying to really attack some of the things that are driving our mortality rates and our morbidity, and what we are concerned with is most preventable, to really get at those things, because that's where you start to see your percentages fall.
Well, I guess I'm naive because I grew up thinking all doctors knew everything about certainly medicine, if not the whole world. And so I'm surprised to see their doctors getting this training. And then there are other professionals, they don't have this training as part of just their normal education?
No, sir. So obstetrics is a very small portion of emergency medicine training. And it is remote to many of these professionals currently. Other disciplines, again, nursing staff, EMS, have very poor training, and nothing is in depth or as simple. It is in depth, but it is targeted and simple at the same time, and it really applies to anyone. So anyone can grasp what we're trying to teach. It's very unique training, and it is alarming that people do not have what they need to at this point, but it's because of the nature of their training. So nothing wrong with emergency physician training. It's just obstetrics is a small portion. So we train our emergency room physicians as well at UMC. So they go through their standard obstetric training from the emergency room, and all come over to Stork every year to make sure they're retaining what we're teaching and to get the extra practice.
I don't have a question, Madam Chairman, but I do have a comment. I was given a tour of the Mississippi Center for Emergency Services a couple of weeks ago with other new senators, and it's a phenomenal facility, and I commend you for y'all's good work and the lives that you save. Thank you very much for all that y'all do.
Yes, ma'am. Thank you so much.
Thank you so much.
So good afternoon. As Chairperson Boyd said, my name is Marty Tucker. I'm Chair of the Department of Obstetrics and Gynecology at UMMC. I would like to thank the committee and thank Chairperson Boyd for the time this afternoon. When I came to UMMC as chair in January of 2020, one of the projects I had hoped to accomplish was the establishment of a clinical nurse midwife service at the university. Nurse midwifery has not been part of our department for almost 50 years now. There was a time when we had a very vibrant service. We actually trained nurse midwives back in the 70s into the early 80s. Three main reasons for this and for this vision. The first, and patient care always comes first, was that I feel like this program would be a service to our patients, giving them another option for obstetrical care. Number two, to address the workforce issues. We have severe workforce issues in obstetrical medicine, not only in Mississippi, but across the United States. And I was thinking that having a clinical nurse midwife service would help allay some of those issues as we go forward. And then thirdly, a nurse midwife service would add mountains of knowledge to an educational program for students and residents. This is becoming the norm in teaching hospitals across the United States, and I felt that it was time that UMMC also be part of that change. So enter Dr. Janice Skaggs. Dr. Skaggs is an assistant professor in our department. She is a certified nurse midwife. She also holds a Doctor of Nursing practice degree and a Master of Science in Nursing with a concentration in nurse midwifery. She has previously held faculty positions at East Carolina, at Duke, and at Vanderbilt. She joined our faculty in October of 2020 and is the driving force to help develop this nursing midwife service at UMC. So I always feel strongly that those who are doing the work ought to do the presentations and get the credit, because she certainly deserves the lion's share of the credit. So I invite Dr. Skaggs to use the balance of our time.
Thank you, Dr. Tucker. And thank you, Senator Boyd and committee, for allowing me the opportunity to speak about nurse midwifery. I think it's a topic that a lot of people in Mississippi, in particular in the Southeast, have some misconceptions about, and I would like to allay those. All right. So midwifery is one of the oldest professions in the US and worldwide. Traditionally, midwives had learned from each other, from other midwives, as well as from their own births and births within the family. In order to better understand modern day midwifery, it's important to understand the differing types of midwives in the US today. I'd like to take a quick tour with a history lesson. In 1921, the Shepherd Tower Infancy and Protection Act became federal law. States were given federal funds for infant and maternal health care education, which expanded state public health systems. From the 1920s to the 1960s, midwives were the heart of Mississippi's public health work. Nurses and midwives worked together to expand the modern public health care system in Mississippi. These efforts significantly decreased maternal mortality in Mississippi. Shortly after the Shepherd Tower Act in 1925, there was an introduction of a new type of midwife, a certified nurse midwife. There was an education program that was developed by a public health nurse in Kentucky, and education criteria nationally were recognized and thus became the certified nurse midwife. In 1955, the American College of Nurse Midwives was established and pushed for a master's level university education as the entry level. We are now pushing for a doctorate level for that in present day. So in that same year that the American College of Nurse Midwives was introduced, the University Medical Center opened in Jackson. And during the period of 1969 to 1985, there was a thriving nurse midwifery education program that was supported with federal funding through the County Health Improvement Program. And this was to reduce infant mortality. Midwives were trained in the local area as well as in North Mississippi, and many of those midwives stayed until the end of that program. So in 1994, yet another type of midwife enters, and there's a new education program nationally called a certified professional midwife. And in 1996, yet another certified midwife. So I see where the confusion lies. For me, it's even confusing, and I'm a nurse midwife. So CNMs are the only midwives recognized by the Mississippi legislature, and I've been asked to speak about nurse midwifery, and that's why I'm here. So quickly go through the other types, and I'm going to focus on nurse midwifery. There are direct entry midwives, which may be certified or unlicensed midwives with an informal education, such as apprenticeship or self-study. Then there are certified professional midwives who either enter through the direct entry program and then sit for a certification exam, or a certified professional midwife can go through an educational program that is accredited by their educational body. CPMs, no matter which route they take, direct entry or through an education program, will sit for a certification with the North American Registry of Midwives, or NARM. And if they pass that certification, they then can practice in a state where they are recognized and licensed. And when we look at the prerequisites for that, these midwives must have a minimum of a high school diploma or equivalent to that. Now, some do have much higher education than that, but that is the entry level. Certified midwives are similar to nurse midwives, except they are not nurses. We actually have the same governing body. We have the same educational certification and accreditation, but they are experts at midwifery. Nurse midwives are actually registered nurses. We're advanced practice nurses who either have a master's or doctoral prepared education. Again, through ACME accredited program, we take a certification exam and maintenance through the American Midwifery Certification Board and maintain that certification. And then we're licensed through states. And nurse midwives are the only midwives that are recognized throughout every state within the US. So with that, certified nurse midwives and certified midwives do follow guidelines. We are outlined from our American College of Nurse Midwives to practice by specific guidelines. And we either practice independently with low-risk OBGYN care, consultation, collaboration with others, including physicians and other healthcare workers, or actually refer patients out dependent on their health status. And we are experts at nursing and midwifery. So in 2022, there were just over 13,000 certified nurse midwives in the US. There were 102 CMs, 2,600 CPMs, and then an unknown number of lay midwives that are direct entry that were not certified as CPMs. In 2022, certified nurse midwives actually attended well over 370,000 births because the number of CMs is so low. And 92% of all midwife births were CNMs or CMs. And in 2020, 10% of the total US births, mostly by CNMs, but some CMs. And that increased during COVID to 21% in 2021, and waiting for the finalization of the 2022 data. So CNMs are the only midwives recognized by the Mississippi legislature by the Nursing Practice Act. So we are licensed by the Mississippi Board of Nursing. We're required to maintain an RN or registered nurse license, as well as a certified nurse midwife license. Currently, there are around 30 to 40 licensed midwives in Mississippi, and much fewer of those actually are practicing. And that's due to opportunity. There are not job opportunities. I think there's some unknowns for many who have not worked with nurse midwives, don't understand the training or the practice. And it's been difficult for nurse midwives to create positions or create jobs in Mississippi. There are more nurse midwifery students in Mississippi, and I can tell you I know all of them because they find me, than there are actually practicing nurse midwives. And these students are not being retained in our own state. They are leaving to get jobs. So they're in programs that may be in another state, that may be a distance program, virtual program, seeking clinical experiences they can't find in their own state. So they're living in Mississippi, traveling to get clinical experience. And then once they graduate and finish, they cannot find a job in Mississippi and they're moving. There are midwives that do practice. Anyone can call themselves a midwife in the state of Mississippi. You don't have to have any special education or certification. It's not unlawful. And there are over 34,000 births in Mississippi. It should be 2022. And a little under 2% of those were actually attended by nurse midwives in Mississippi hospitals. So I think we've got room for improvement, expansion. So what does a nurse midwife do? I think understanding what our job is every day and the kind of care that we give is really important. We give care during pregnancy, childbirth, postpartum period, sexual and reproductive health care, gynecologic and primary health care from adolescence through the lifespan. We provide family planning services, including preconception care, which is very much needed. We also can care for our newborns up to 28 days of life, provide initial and ongoing comprehensive assessment, diagnosis, and treatment, prescribe medications as appropriate. And the hallmarks of midwifery are health promotion, disease prevention, risk assessment, education and counseling in a variety of settings, including ambulatory clinics, inpatient, as well as telehealth. The research is clear and the evidence does support midwifery-led care. We know that if we integrate midwifery into a healthcare system and have infrastructure and support, that we will see decrease in unnecessary interventions for low-risk women. We will see an overall improvement in outcomes and a reduction of cost. If we have midwifery-led care, we have a lower unnecessary cesarean section rate, which in turn decreases severe maternal morbidity and mortality, increase in the rate of successful vaginal birth after cesarean, increase in spontaneous vaginal birth, decrease in unnecessary episiotomies, significantly lowers the preterm birth rates and low birth weights of neonates, a significant issue in Mississippi, and increases breastfeeding rates for initiation as well as continuation of breastfeeding. There was a public policy paper that looked at increasing the percent of midwifery care in the US from 8.9%, which was in 2019, up to 20%. If we could do that by 2027, it could result in a cost savings of $40 billion, 30,000 fewer preterm births, and 120,000 fewer unnecessary episiotomies, not to mention overall positive experiences for patients. And when we look at options for care and look at satisfaction and trust within the healthcare system, midwifery could be a bridge for trust within our own healthcare system. So at UMC, Dr. Tucker called me and said, I'd like a midwifery service. What do we need to get it started? And I said, well, I think I need to come and just feel it out and see. Let me observe, let me follow, let me see how the system works. And so 2 years later, we developed a 5-year plan to start a 24/7 nurse midwifery service that could offer care for low-risk obstetric patients and gynecologic patients. We are now in year 3. We have 3 certified nurse midwives that are on staff. We work in the hospital and 2 clinics for UMC. And our goal is that beginning of next year to hire 2 more, so we'll be at 5. Our hope was to be at 6 about this time, so we're a little behind that, but we're working towards it and almost on track. And we hope that by the end of that 5 years, we will have 8 certified nurse midwives as a minimum, that will have multiple clinics to offer services for patients in areas where there is no obstetric care or minimal care. And our hope is to continue to be integrated as we currently are with medical education, as well as OBGYN resident education, in order to provide a population within the university that we don't always see being lower risk women who are giving birth. So with that, I'd like to thank you for your time and open up for any questions.
I would love to ask both of you just a couple of questions. I'll be candid. I started going to conferences and on maternal health care. And what I noticed is when presenters were speaking in other states, the midwife was a part of the team. I subsequently had conversations with physicians in other states. And so there was the healthcare team for a woman was her OB/GYN. There was often a midwife on the staff. And then then they worked hand in hand, actually oftentimes with even a doula that was incorporated into their practice. And what I noticed repeatedly is those states that where you saw this more prevalent had much better maternal outcomes than what we did. And I think sometimes that people think as a midwife replacing a physician as opposed to them working hand in hand as part of a team. Can you address that just a little bit? Because I do think there is this mistaken perception on that. So.
I think it's about education and it's about culture change, and changing culture is very difficult. That's one of the reasons when Dr. Tucker said, how many midwives do we need to start a service? I said, do you want it to be sustainable? And he said, yes. And I said, then you start with 1 and put me in the hospital. Let me see what the culture is like. Let's see how we can add some things to culture that maybe is not there. And what we do know from the evidence is if physicians and midwives are on the same level of understanding and support for physiologic normal labor, we have significantly better outcomes. If the midwives are here and the physicians are here or vice versa, then we're not working as a team. We don't have the same philosophy, and our outcomes in that institution are not going to be as good. So I think education is number 1. I think dispelling myths about nurse midwives. I think having more exposure throughout the state would be really helpful so that people understand what we can offer. And I think working as a team, I think all women deserve an OBGYN or high-risk specialist in OB and a midwife. And I think that's the way we should look at it.
Senator Boyd, you hit the nail on the head, and that's exactly what we're trying to accomplish at UMMC. As Dr. Skaggs said, my thought was to go out and hire X number of midwives and start a service. That's not sustainable. We want this to be a proof of concept that we can establish this, make it sustainable, make it consistent, make it be part of a team, and then kind of go from there, because there's a lot of talk about different hospitals doing this or putting midwives in this place or that place. At least from our perception, that's the wrong way to go about that. That we think that the concept that we have established here and trying to prove that concept is going to be what's going to be sustainable, and take that model over the next decade and make it work in other places too.
Do y'all have difficulty with reimbursement from any of the private and public providers for these types of services?
Since I have come here, we have not seen any difficulty with getting reimbursement with billing directly for midwifery care.
We were hoping that question would come up today, because I understand it that midwives are reimbursed at 95%.
90.
Oh, excuse me, 90%. We would love that 10% extra from Mississippi Medicaid, and hopefully other private payers would follow that along. We feel like the reimbursement for same services ought to be equivalent.
Tell us just a little bit, because we don't understand the difference in your role and your role in a delivery. Is it the same or is it different? Tell us a little bit about
Yeah, if it's a normal vaginal delivery, and in general, midwives are specialists at low risk, normal, healthy, although we can work alongside consulting physicians to take care of high risk patients as well, as long as we're consulting and providing that care as a team. But if I'm going to take care of a woman, I'm going to go in, I'm going to meet her. If I haven't met her before, I'm going to get her admitted to the hospital, follow her through her course of labor, and help to, I always say pizzas are delivered. Moms birth babies. My job is to make sure babies don't fall on the floor. Most of the time emergencies don't happen, but we're well trained if emergencies do. So birth of that child, if there is any need for repair of a laceration, I would do that, and then take care of that mom postpartum, and could take care of her throughout that process and discharge her from the hospital. And then follow up in clinic.
And if there's a high risk situation, that's where Dr. Tucker.
So if I need to consult for, say, a mom with severe preeclampsia, I may call Dr. Tucker or Dr. Morris and say, so our mom has developed preeclampsia by this criteria. I need to consult with you. I would like to manage her labor and stay with her. We have a great relationship, but I would like for you to manage the high risk medical part of that. Or if there's a need for a C-section or a vacuum assisted vaginal delivery, those would be other times that I would consult during the process of labor itself, or if it was an abnormal labor and things weren't going normally.
So I mentioned earlier that patient care always comes first, and what is 1A, probably even more important, patient care is safe patient care. And so having this infrastructure that Dr. Skaggs just described to you, where they're managing the low risk, the routine, odds are that that patient will never need to see an obstetrician. But if something develops during prenatal care, during delivery, or even the postpartum period, that infrastructure is there to take care of that patient expeditiously and safely.
Okay, and you mentioned that so right now, I think you said that y'all were trying to move to, so you have your advanced nursing degree, and then y'all are trying to move to even a higher level. What did you say on that?
Well, master's level is the entry level for a certified nurse midwife now, and our organization is moving towards the entry level being a doctorate. So a lot of programs across the country are moving away from the master's and moving to a doctorate program. And most of those are doctorate of nursing practice, although some of those are PhDs in nursing.
Okay, and I saw that, why did we stop doing?
It was funding. It's funding, and you've got to have people within the state to be able to support it. And when funding runs out and there's no plan for how to continue, and there's not support within the healthcare system and infrastructure, it's exactly what happens. It goes away. And I think if midwives are put in places where that infrastructure and support and relationship with our consulting physicians is not there, then it's a real easy way to have midwives for a brief moment and then they're gone.
If you go back, and I had mentioned that since the late 1970s, and then Dr. Skaggs on her slide said 1969 to 1985, we're actually both right, because you go back and look at the catalogs from, say, 1980, 1985, it was still on the books as a program, but there were no students, nobody being trained, and it was because of lack of funding. So the last midwives that actually practiced at UMMC were probably sometime in the mid to late 70s.
Okay, and y'all said that there's not jobs for, so there's no like hospitals that are employing the midwives, or, okay.
I moved back to Mississippi. I grew up, went to college, left, came back in 2016, moved to the coast. And that was in end of 2016. It took me 4 years to find a clinical nurse midwifery job in the state. And I had over 15 years of experience. I wasn't a brand new graduate. I was somebody who was innovative, who was trying to get out there and meet people and figure out how the system worked. And thank goodness for Dr. Tucker and UMC. I'd be back in North Carolina.
Y'all have additional questions? Senator Bryan? Questions? All right. Well, thank you very much. I'm kind of fascinated as to with our healthcare needs while we don't have more practitioners out in the state at the hospitals. So thank y'all very much. We really appreciate y'all presenting.
Thank you for your time.
Dr. Stratton, you have hung in with us all day long. Thank you for hanging into us. You've been here since the very beginning today. So
It's been perfect.
but you've got some good news to share.
I do. I'm a trained psychologist, and one of the first things my faculty taught me was you leave people with hope. So that's what I'm going to do for you today, is leave you with a little bit of hope. And I'm here to talk about the early intervention pilot project that we have partnered with through the task force as well as the Department of Health in moving this forward. But I did want to give a few stats for you based on the autism presentation you had earlier today, if you wouldn't mind if I go off script for just a minute. Senator Boyd and I got to know each other before she was Senator Boyd, and was a mom on a committee establishing our licensing board for the practice of ABA in the state. And we were a very efficient board, and we have continued to do that to where we have 235 licensed ABA professionals in our state, and we have many programs ready to pump them out to stay here. But your parents told you this morning, Medicaid is not being taken by many of those practices. There are 3 practices in our state that take Medicaid. Those rates are significantly impacting the amount of work that can be done in keeping people here. And I watch at Mississippi State, our graduates leave the state every year who are by far exceptionally trained with outstanding clinical work before they ever get into their real job, because we don't have the rates where they need to be. So I say that as somebody who's been one of those Medicaid providers at our center, and you wouldn't survive if I didn't have private insurance and if I wasn't at a university that could help support some of my buffer. It's really important to consider. And I just wanted to share that stats with you, because when we say it's a handful, I think it's very different than 3. It's 3. But let me turn to early intervention, back to hope. Okay, so we are first very thankful to be here, and I appreciate you giving us the opportunity to talk. And when I say us, I'm coming on behalf of the team that's been set up at TK Martin Center. I have got a phenomenal team, and they have worked very hard over the last 11 months to have outstanding outcomes. But I do also want to thank Dr. Edney, Dr. Witt, Dr. Tammy Brooks, who have been right alongside us throughout this journey, particularly as part of the task force, but also as we're running a pilot project, which means we're trying new things. And sometimes we hit roadblocks and we have to talk through that together. And sometimes that means like, why aren't we doing this for everybody? You know, and it comes into those conversations. And I just appreciate an open door, open cell phone. There's text messages all week long about what we can do to help improve outcomes for our children. And I just want to make sure that's recognized, that this is a team approach. But But I do want to quickly touch on why we got here, and Dr. Buttress touched on this very briefly this morning. In Mississippi, with the idea that the pilot project came about, as well as the push from this committee in particular to help make sure we are seeing some outcomes, is this is ran underneath the Office of Special Education Programs at the federal level and under IDEA Part C, and they give an annual state performance report. And unfortunately, early intervention was at a needs assistance qualification from 2016 to 2020. In 2021, we hit a needs intervention. It was us in Indiana. Okay, so not even our partnering states who see similar socioeconomic issues, us in Indiana. Jump forward to y'all first beginning to meet, we saw that we are serving only approximately 1.5% of our birth to 3 population, with those estimates being at about 13% that we suspect. That is not at-risk children. That's just our guesstimates based on how good we are at recognizing the amount of disabilities we start even seeing coming into our K-12 setting. If I had to put on my great practitioner scientist hat and say, is that number enough? I would say no. That number should probably be higher. And when I came to this state almost 12 years ago, my very first meeting was a First Step State ICC meeting, and they were saying where their data was. And I remember getting in the car to drive back to Starkville, and I said, where are all the babies? Because our numbers were so low. And we've got to work to improve that. So as a result, the task force was formed, put out great recommendations, as Dr. Buttress mentioned this morning, but it coinciding with that, we started the pilot project. Unfortunately, it took us about 6 months to get our MOU in place with the Department of Health, and part of that was already seeing the need for some policy and structural changes at Department of Health. And so as they worked through that, and we got a great team in place there, we were then able to begin the pilot services. So we are just in 11 months of this pilot project. And then, as you can see, in this July, we again had that task force move forward, and thankfully we've been refunded through June of this coming year to be able to see the pilot through. I am very much a data person and a problem solver. So when we came about this, I wanted to look at a model that was effective but efficient. I don't want to waste time in getting to the right answers to help more children. We want to get to them as quickly as possible. We want to have the biggest benefit with the lowest cost, but we really also needed to focus on OSEP's IDA indicators because we're failing those. And we know that as a state that they need improvement. We also enlisted the Social Science Research Center to do an independent review of our data, and they're also going to be conducting a survey of family and provider outcomes. So the data I give to you is data I have collected. This has not been independently reviewed and will go before that because I think that's important that we make sure we have outsiders taking a good look at our work. So what happened? We took over what is known as the Central East region for early intervention. So we serve 11 counties in our pilot project and essentially plucked that away from the lead agency, but fall underneath their purview to help support and make decisions. So we're not changing necessarily anything our lead agency does, but we change the model of what that looks like. And I'm going to talk about that to you. But I do want you to keep in mind, I remember my first meeting with Dr. Witt, and she goes, good golly, why did you pick 11 counties? And I said, well, part of me was thinking smart about this and part of me wasn't. I picked 11 counties because I really wanted the geographic spread of Mississippi and our demographics to match. I knew very well that if I chose Oktibbeha, Lowndes County, y'all would say, well, great, you got those college kids. What are we going to do about this, right? So we were purposeful in that. However, we've probably bit off a little bit more than we can chew with 170 plus miles one way to go see a family. It's a lot, but I want you to keep that in mind as you see our data because it's very impressive. Okay. If you're not familiar with early intervention, on the left is how the typical model looks in our state right now as funded by the lead agency. So a family is identified as being eligible for services from an evaluation, and then they typically get one of these 4 therapies, if not multiple therapies as a result of that. We are not meeting families in the natural environment as demanded by OSEP, not even recommended, demanded by OSEP. So as a result, what this is a parent takes their kid to speech therapy, a parent takes their kid to occupational therapy, maybe a special instructor comes to their home, and then there's a service coordinator who oversees that whole case, okay? That's important to keep in mind because for our model, we've moved to a primary service provider model where you have a service coordinator get your case started, get you eligible, and then you get the one provider that we think is most important to your needs while they have access to a whole team of providers around them. So cost savings, number one. Okay, we're not paying for extra services that we might not need. And this is based in really good science, and that we'll talk about in just a little bit more. But on the bottom of this circle are all the services we have as part of this pilot project. So within this model, we work in close collaboration with our team members, but there's that one provider who goes out. As a result of that, we do sometimes have joint visits and consultations when it's a more complex little one who might need some additional supports, or that provider says, gosh, I really would love to do this OT related thing, but I need some pointers on how to do that support. Really what this model is parent and caregiver coaching, okay? We are coming into the natural environment, into their everyday experiences, and teaching them how to teach when your kid doesn't know it. And when you don't have to set aside as a parent the time to go, oh, we were supposed to do 15 minutes of speech today. When are we going to fit that in? I'm a mom of two. I'm a very busy woman. When my 8-year-old brings home homework, I think, oh my God, when are we going to do that? We don't want families thinking that with the baby that's already fallen behind. Most importantly, what we've heard from our families and from what the data shows is there's one professional voice coming to that family. So they're not hearing something different from a physical therapist than their occupational therapist and their speech therapist, all of whom likely have never communicated but are giving them insights on what to do next. And that can be really confusing for a family. So they get one solid message coming through in this primary provider model. So what have been some of our outcomes? When we started this project and up until October 30th of this year, we've had a total of 440 referrals in those 11 counties. When I took over the Central East region, there was 107 individuals pre-pilot in those 11 counties. We're up to 160 individuals in those 11 counties right now. We have one service coordinator. Typically, this would be a job of probably 3 to 4 service coordinators, so a cost savings there as well. And we've seen that 50% increase in the referrals. To be honest, when we started this project, we were knocking on pediatrician doors, daycares, telling everybody about it. We've had to slow that down because we would need more staff in order to keep that rolling forward. And as a byproduct of that, we're already in discussions with a hub hybrid model that's being recommended by the task force of what do we do when a collective kind of gets over, they're full at capacity, and how do we still help support the lead agency in moving forward with that care? So our referral sources are primarily coming from physicians, the NICU, CPS, parents, therapists, and daycare. I will say I'm pretty sad to see that our therapists are only about 5% of our referral cases, because what's typically happening is a pediatrician is writing a referral to early intervention, and at the same time, they're writing referrals to outpatient services. Those outpatient providers are not recommending families into early intervention until they've exhausted insurance. That's a problem. They should be counting in our numbers because that impacts the whole system and how we look at what we receive from the feds as well. For our eligibility evaluation, so this is the evaluation a family gets to make sure their child is eligible for services. In our pilot project, we have about 260 evaluations we have done. We have outside of the pilot, so outside of our Central East region, we have done over 100 just to help support the regions around us in need. But that suggests then we've evaluated more than 60% of the individuals who've even come to us for services, which is pretty good response rate in the grand scheme of reaching out to parents and tracking them down. One of OSEP's primary indicators is a timely provision of service. How quickly do you get from referral to somebody in your home helping your baby? And this is an area that I'm sure we're probably going to get dinged on in our OSEP review. As a state, you can see our data in the chart here, ending most recently with about 81% is where we want that to be. Of course, OSEP would love these to be closer to 100 of where we're at. For our pilot, from the point of referral through, we're at 87%. I would say if our If our mighty data were corrected a little bit, we would be above 90. So we're making really good progress in getting services in a really timely manner to our families. Indicator 2 is our this is a big jump. Indicator 2 is our services provided in the natural environment. The natural environment is demanded by OSEP. That is for a lot of reasons that I'm going to touch on in just a minute. But if you see the bottom line here, this is Mississippi's data. We are falling very, very far behind in a natural environment setting. So I think that last number was 65% of our services for early intervention were in the child's natural environment. For our pilot project, 97% of our services are in the natural environment. We had heard before starting this pilot from a lot of therapists that families do not want you in their homes. That's why they prefer outpatient services. They don't want you to come in. We have had not one family tell us, I don't want you in my home. And actually the families we're seeing outside of the natural environment are because they're either moving or their home was being under construction and they didn't want us to come in because it was under construction. We are in the daycares and have been very welcomed into those settings. We've run into no concerns with that. And then we see just a few children at our center and at the health department because of those family requests. So I do want to touch on the benefits of a natural environment, and I appreciate that you asked about the collaboratives this morning and how could this all come together. And really part of that mandate is we're supposed to be in the natural environment, not because it's a place, but the process of what happens in a natural environment. And this is where we can really make some meaningful difference in our state, is we want families and children to learn through their everyday activities of what they do. So our therapists are outside on the swing set, stopping the kid from eloping into the yard while teaching communication. They're at the snack time in the home. They're observing things like, is the high chair appropriate for this child anymore? Are we laying that child on their back to sleep? What are we doing in that setting? And we get to see so much more in that natural environment than we would have ever have seen elsewhere. Every single therapist I have on this team came from an outpatient service or a home-based service. And they all have said, I would have never have known any of these things about my clients had I not been in their home, because it just opens the door for us to have so much more dialogue. We can build it around the family's routines. The parents are there getting coaching, the early childhood providers are there getting the coaching from our individuals, and ultimately all the other kids benefit. I actually just went to see our speech therapist who was seeing a little one in a daycare who was having some pretty significant behavior problems, and that's a real expertise of mine. And I came in and it was funny because the moment she sat down on the carpet, so did all 12 other children. So guess who got early intervention? 12 kids that day. It wasn't just the one who was there. And that's the goal. It builds into the setting so everybody gets to be involved. We can identify earlier skills. It's faster rapport with the children and family because they're comfortable, but then we can identify what needs they require. One of the children that we recently went into the daycare, unfortunately, it's a pretty impoverished daycare. The only book for a 2-year-old was a National Geographic magazine. That's inappropriate, right? No wonder we're not pulling that kid in. So we've put in a lot of resources there. We've connected that daycare with other resources of what they need to be successful. But our speech therapist or early childhood instructor would have never have noticed that had they not been able to go into that natural environment. Indicator 7 from OSEP also looks at how quickly we meet our 45-day timeline. So that is from the point of referral to the point at which an individualized family service plan is developed. As you can tell, Mississippi's had some history of dropping down below where we would like to see compared to the national average. Recently had an uptick in that most recent data. If you look at our average, we're coming in at 45 days. We are inundated with referrals at the moment, which is slowing us down. If you look at our data based on the family canceling services or not being there, we're at 92%. Again, meeting on, really, we're beating the national average at this point in both of those key indicators. And keep in mind, that's one service coordinator to all those referrals, the cost savings we have and the amount of geographical area we are covering. So as you will see in that task force report, there's been the recommendation of a hub hybrid model, and we're not calling it a hub, we're calling it these early intervention collectives. And what we hope is that RFPs can come out from the Department of Health to do similar programs of what we've done in the pilot in regions across our state, particularly in our underserved areas where we know we need more support, while then the lead agency is still there tapping in and filling in the blanks of all the services that we need. What I think you will find here is significant cost savings. There's fewer service coordinators on the front end. There's fewer providers needed. If you do a primary provider approach, you're saving significant dollars by just not sending them to multiple people. You have fewer Medicaid transports because we are coming into that setting and providing the services. We have faster gains because it's generalizing to the family and their needs. And with this collective, you have built-in monitoring. I see my team every single week. We have a group meeting every Wednesday. We discuss almost every kid on the caseload for case management, referral supports, needs that our therapists have. I know where they're at and what's happening. That's been a bit of a challenge for First Steps to navigate with multiple contracted providers across our state. But in that natural environment, our siblings are benefiting in that home. The amount of young children that we're watching of younger siblings who will benefit from this service is remarkable. Our grandparents and aunties are benefiting because they're the ones watching the babies during the day. We have pulled them off the couch and onto the floor, and they are playing. And now they're meeting us at the door going, "You will never believe what he did. I took a video. Can't you wait to see it?" We wouldn't get that outcome if they weren't involved in that environment at all. But we're also catching those families who might not be able to make it outside of their home, those medically complex kids. And y'all, we have them. We have a baby right now who's likely going to die before the age of 5. And it's because our therapist caught the genetic concern soon enough. And it's likely going to save the younger sibling's life because we caught it soon enough. These are really big things that because we're in that space, we're able to provide that support. There's also benefits to your provider. If you listen to any of the task force members, a lot of the providers say, I just kind of feel isolated. I don't have a lot of support to talk with other people about, what's the best research to do in this situation. We have that multi-provider support, and really that ultimately means our providers are getting excellent professional development and many more resources. So we can refer to healthy moms, healthy babies. We can say where a daycare waiver is. We can tell them what dentist will see them until they can get insured. We're using those things to make sure that whole child is getting met, not just with the early learning needs. It's a workforce development. If we do these within our university-based programs, we're training the workforce. In 11 months, we've had 6 interns come through this program, one of which I've hired as a special instructor when she graduated in May. We have status updates for our physicians that haven't received those to know what services the children are getting. Our schools have been thrilled when the child turns 3 to see us show up and be able to talk about all the things we're doing in the home so they're prepared to take that student in. But I think it's going to help us also pilot. I was talking to Dr. Wood about this. I said, nobody ever wants to ask this question, and I can't find it anywhere, including our technical assistance center at the federal level. What do we do when a kid's so good they don't need early intervention anymore? Because we're finding it. Isn't that great? That's the whole goal. But there's no process of how you exit early intervention until you turn 3. Well, we're going to have to figure that out. And that's part of why the pilot's here to talk about that, because we are in early intervention. We're not an enrichment program. And once you are reaching your milestones and doing really well on that % delay, we've caught you up. We want to make sure you're successful and ready to transport to wherever you need to be next, but we've got babies in line waiting for us. I just thought it'd be helpful to have a parent perspective. We did have a parent of an 18-month-old who wasn't speaking. The physician referred them to early intervention, also referred to speech and OT outpatient. Straight out of the mouth was, you really don't need OT, but they'll pay for it, so why don't we send you to it anyways? Frustrating. Parent started outpatient, was a total disaster. The kid screamed for 2 hours straight across both therapy sessions, hated the environment. They got assigned to our pilot, and the parent says this is just like the most life-changing experience. They were more involved in the plan of care for their child. They could get many more feedback and pointers than they could get from the therapist. This is one of those kiddos we're working on making sure they don't run away from their parents. When we talk about drowning, when we talk about some of those other risks, these are our babies that are most at risk to do this. The amount of home cheap alarm systems I have recommended from Home Depot or Lowe's, I should get stock in what I have for them, because this is where we have to provide that safety, because the babies don't know and they're at high risk of those things. We encouraged a daycare part-time. This was a parent who was really hesitant to put this child in daycare, had only been with a mother or an aunt for childcare. We encouraged that part-time, huge improvement in social skills and speech. And I said, well, is there anything that you wish that we would do more for the program for you? She goes, well, can't she just come a couple of times a week? That tells me we're making a really good outcome, and she just wants more of what she's getting. So for next steps for our pilot is to obviously support first steps with the task force recommendations. We are a partner in this project. We will need continued funding. I think that if we look at putting out a request for proposals for early intervention collectives, it's going to take time. It takes time to get those requests for proposals out, get them reviewed, and get them moving forward. So that funding will need to continue for us to keep doing this good work. We also will have the independent review by the Social Science Research Center, and that review and the surveys will also help First Step meet some of their federal mandates that they need moving forward to know our parent outcomes. So what is the overall next steps that y'all might need to consider for us? We've talked about the greatest return on investment. It's around 13%. I would love to know what that number would look like for Mississippi, because if we look at autism data in Mississippi, it's actually much higher on our return on investment the sooner we get a baby in ABA. Part of that is the lost, you saw both parents say, well, we couldn't work. Well, now we've lost a parent income for how long? And if we can't catch this kid up, now we've lost them being a citizen in our community that's contributing to that. We need CBT codes for early intervention from Medicaid that can go in the natural environment. Right now, Medicaid does brick and mortar. It does not do a natural environment, and we need codes for early intervention in that natural environment. We need developmental therapy codes for services in that natural environment. Our eligibility assessments should be covered by Medicaid. They are not. That is payer of last resort coming out of First Steps. So that's just killing the budget right away. You just saw I did almost 400. We're probably pushing 1,000 or more of those. We could pull the data, but that's just killing our numbers. We need those covered by Medicaid and hopefully then by private insurance as well. The EI eligibility, the fact that professionals who have come in who know child development have said this child's eligible for early intervention services should be all the pre-authorization they need to get speech, OT, special instruction. That's not the case right now. So if I were a provider, I then jump through the hoop of early intervention eligibility, and then I've got to get that physician to give a pre-authorization for all of these services, yet we don't even have the early intervention codes for that to occur in the setting it needs to. I would also love that the agencies could be contracted by Medicaid, and by product of that, when you contract with Medicaid, you're contracted automatically with all the MCOs. Me learning to navigate insurance is the reason I never went into private practice, and here I am figuring it out anyways. It is such a battle for our contracted providers in First Steps to become a provider, one, for early intervention, but then they have to take insurance. So you're looking at whatever private insurance is in that state, in that region. So if that's, United or Blue Cross or Blue Shield, whichever is most common in your region, plus Medicaid, and then all the managed care organizations, that means I need to get contracted with like 5 to 8 insurance providers. All of that takes 6 months or more to be able to move forward. And meanwhile, babies are sitting in the dust while we don't have any of this moving on. We need to focus on the recommendations that have also been brought forth by the task force. That group was amazing and put so much thought into what was put into those recommendations. And we have the support from First Steps and Department of Health to move this forward. We need these things that seem like, to me, they seem like such easy fixes. but it really corrupts the whole system if we can't keep those things moving forward. Questions?
Bryce is sitting here asking me questions, and I'm gonna ask, it may be a group project right now with that.
Absolutely.
How much did we put in last year for early intervention as a state? Do you remember?
Please. I think it was 3.6.
Yeah. Because y'all use some of your discretionary funds to fund it. So, and we have to put in 4.7 just for this, for the federal, like to maintain that federal level, right? Okay. I'm making sure on that. No, and then yeah, and that was a special pilot program funding that went through, I believe your IHL budget. With that, if I'm not mistaken. I want to go back because I want to make sure this committee is fully aware. So, natural environment codes. The federal government requires that, as they're saying, that the indicator that these services be done in the natural environment. And as I can say, having had those services in my home for my child in another state, when it was in the natural environment, it is an incredible resource because it teaches you how to do those therapies when they're not there. So you get incredible bang for your buck because they're teaching you how to do this in your play and in your area and all of that. But Medicaid does not reimburse for services in the natural environment. They only reimburse for clinical settings. Y'all help me out here. So that's a problem that we might need to try to figure out how to address because that's with that. The developmental therapist codes, we have a problem with that with Medicaid as well. Am I correct? There are none. There are none. But to get private insurance, you need a evaluation from a developmental therapist, a developmental therapist or a physician in that for private reimbursement. So, okay. And then the assessments are not covered by Medicaid at all. Okay.
And that we've done. So almost 500 evaluations coming out of our side for that. I think, Anna Lynn, the 68% ineligible rate was for the state you were finding? Is that the number you just gave me earlier?
So in the comprehensive assessments, and this is not official data, I just ran it because I was interested when I was at a Head Start meeting last week. And I determined that out of November to November, there was we were doing evaluations and 68% of the kids weren't quote unquote eligible. Now, of course, when I went back and looked at the actual case numbers and case files, having those program coordinators reassess. But I think that's also a factor of not having enough staff, not having enough therapists, being able to find the services for the kids. And so there may be this perception of, well, if we don't have the services, then the kids, we'll just deem them ineligible. And I don't know that for sure, but these are just numbers that I just came across.
So having friends who are some of those early intervention providers too, I know it's also a training issue sometimes with new therapists who come in, and we have a very, because of low pay, low reimbursement, we have a very big turnover rate. Would that be accurate to say? And so sometimes it is a knowledge base and a training issue of those newer ones. Is that correct?
I would say that might be part of it. But I think we have good training opportunities, particularly what Department of Health is looking to roll out now in the future for those training opportunities. I think that one of the challenges is if I'm a provider, assessments, I don't have to be credentialed with any company or contract with any insurance company. It's easy for me to take in as many of those as I would like. And if they say they don't maybe have somebody to see it, for me to say, oh, okay, well, then they might not be eligible. However, I also think that part of that training piece that you speak to, Senator Boyd, is really important because there's 3 ways to become eligible for early intervention. And one is a 33% delay, a delay two delays of 25% or more, or professional opinion. And I think when you are not in the natural environment, you can't put that professional opinion hat on. However, many times we have put that hat on to go, oh, that baby is 30% delayed, but oh my goodness, look at what we need to do here. That baby needs to qualify and we need to move them forward. So to put that data in perspective, only 10% of the assessments we have seen have been ineligible.
All right, anything else I want to bring up? Questions? Yeah, Bryce.
Can we go back to the slide that had your referrals? So
Who's
I was-
referring?
I was glad to see, and coming from my perspective of what I work on, the CPS. But let's see.
And I would
So
say-
how have you experienced with either with the youth courts? Have they sent you referrals?
Unless they've come through CPS, then we wouldn't have had any youth court referrals. And so I will say CPS, that's 22% of our referral sources, but they're almost 23% of our caseload. So we're getting a lot of CPS referrals. And I will say our physician referrals, I don't know what our statewide data looks like, but this is a huge increase in those 11 counties. We had to go in and tell these physicians, you're ready to refer to First Steps again. We are here to serve you. And that took some winning them over a bit because they were pretty frustrated with the lags and delays that we had historically seen in First Steps. So this was our team reaching out to those referral sources, but CPS, I think, has just been a much better partnership amongst those agencies
Well,
making.
I would suggest even, so I'm suggesting to reach out maybe to the youth court judges, because what happens is they come in and CPS, they can do cases that aren't within the court system, but the court system, the judges refer, they have things called, depending on where you are, in circle, where they go into the home, which has been very good. But I guess to your point, I guess if CPS is usually involved in that. So, but I think the judges could also help with that. And then I just want to give I guess a little bit of a testament. I didn't know anything about it. Our son was elementary school. And this goes to your point about do it and move on, but probably we think it was because he liked to suck his thumb. And he had it was a lisp. He couldn't, it wasn't good. And they referred him to speech therapy early. And I guess it was it was done. And he never had a problem after that.
Yeah.
And I didn't know anything. We didn't know anything about that. And so we certainly benefited from that kind of stuff.
Well, and if you think about that, speech is something we all do every day, right? We all communicate, and it's something so natural for us. But then imagine that parent who has the baby with the medical complexities, who's like, what the heck what do I do? Or you have the child that you're suspecting has autism, and they're climbing through your kitchen and they're running out of the house and they're stimming in the corner. We had a mom just this week with 6 children and her last child has autism. And she said, ma'am, I have no idea what to do with him. And I said, I know, because he's not like the 5 babies you had before this, but that's why we're here to support you. She had 5 children doing well before this and is sitting there going, what do I do? And so you go from something as minor as a little lisp that we know we can knock out and do that. But now if this mama just gets a little bit support, we can get them into the services that they need. This baby's gonna be okay. He's very bright. If he can figure out how to get out of his car seat while it's strapped and climb on top of the roof of the car and get to the graham crackers mom set up there, we can surely teach him some things,
But-
right?
Right. Your hope, but it's that gap between when the parent recognizes and then actually doing it. Like that person didn't even know it.
Yeah.
So I guess the question is, how do you get people to know or
So-
to know that's there?
So I do.
We didn't know it.
So true. And sometimes that's hard for us because we live in this world to think that everybody knows these things,
That's
right?
the point I'm trying to
That's-
make is I am not of your world. And
Right,
so it
right.
took me by
So these are
surprise.
things that we push for our physicians at all the well baby checks to be doing screenings and that they know about early intervention. I think we could do some more pushes with those things as a collective group. We do need more pushes into our daycares. Our daycares should be a little bit higher in who's making some referrals here. But I think our daycare folks in those settings need support in how to broach that conversation with the family because they're the first line going, oh, we're seeing some red flags here. What can we do? And while maintaining that relationship and moving forward, we have went into many of the daycares in Starkville and talked to them about early intervention and have encouraged their families to come in just so they can hear about it, whether they think they need it or not. And that's gotten referrals too. But I do think we need probably more public awareness campaigns for early intervention. But it's the same thing with special education. Many families still don't know that they can get speech services at school, and we can do that. But I think our challenge is don't shoot the messenger. We need money before we get more referrals. We're at capacity. And when we look at our model for our state, we won't be able to ever take in more referrals in the way that the lead agency runs it unless they have more money. It's not possible. And I see what our team has done with just 5 of us to try to meet this much of a demand. And we would love to meet more. We're now hitting capacity. So we really need the funding before more referrals come in. It's not a matter of needing the referrals. Those babies are out there. They will easily get to us. It's a matter of how do we serve them. And I say this with almost everything. I'm a school psychologist and a behavioral psychologist. We can screen and refer for days for just about anything. But if we don't have the programs to help, it's a waste of everybody's time. And so I put this out to just about everybody. If we screen a high school for mental health and 30 kids flag for suicide risk, now we just know we have 30 kids at risk for suicide and we have no program to give them. We know we have probably 20% of our population and kids that need early intervention. We just don't have the money there to give it to them.
I can clarify, I'm going to take off my health department hat in case I get in trouble with Dr. Edney, but from putting on my pediatric advocacy hat and some other hats. So we are working with a pilot, I'm excited to say, with the youth court in Forest County with one of our pediatricians and to connect that program with infants referred through that program with early intervention services. So we're cranking that out. And
How's that going?
well, we're just beginning. Our national partners put us together.
How did that come about?
It was at a national conference and our national AAP state government affairs dialed us up and said, hey, we met this person. It's a wonderful youth court advocate. I'm not sure I'll misspeak her role and her name, but anyway, y'all need to connect. And so it's going to happen. And we'll start there. And we have a judge who's, I mean, you get the right people at the right table right here, and then you can develop a model that works, you hope. Just speaking about funding and Medicaid reimbursement, it's a vicious cycle, as we know, but we're using all of our polar funds for things that we could use for education, training, oversight, accountability, staff, monitoring that we would not have missed a lot of this perhaps and be in this situation, but the services aren't being covered by Medicaid. And there's 2 points. There is a place of service code that's really automatically denied if it says in the home, because that's interpreted as home health. So there's a lot of discrepancies. We are advocating as pediatricians and EIP providers with them, but it may need fixing with you guys and addressing. And also to clarify, contracting is not credentialing. That is, we spent a lot of time with the task force educating on that. We do have uniform credentialing for all providers, not just EI, but contracting is a bear for every provider type. But if at least for this population, we could simplify that and make that easier, that would go a long, long way and help us have the providers to do the services and get reimbursed. And then we can use our state funds more appropriately. I'm done.
Thank you. Thank you. Thanks for the opportunity.